speaking here? Yes. Right. I am speaking here and recording here. Also, some of you don't have rides on the schedule, and that's because you've taken your sweet time getting your stuff into Charleston, and they take their sweet time getting it back to me. Although Chief McGeorge has done a phenomenal job trying to get you guys on trucks, he couldn't put some of you on trucks because you didn't have availability put in, or you didn't have your waiver completed correctly, or you didn't have your shot verification done yet. So there are a good bit of you who still can't get on a truck yet, or you've gotten all your stuff done now, but we haven't been able to schedule you for a truck because of your delay. If that causes you to delay to the end of the class, you cannot graduate this class. So that is what it is. I'm going to hope to get it in on time. And if we do, great. And if we don't, I think every opportunity that could have been afforded was afforded. So I will leave that there. Matt Gaskins, we are doing 15 trauma module adaptive tests required for the exam. 15 trauma module adaptive tests. The practice tests are going to be necessary. You have to have done at least 15 to go on to the exam.
You are now muted. You are now unmuted.
All right, let's take attendance. I believe that I have not put in lecture assignments yet, so I will go back in and do that. And then I will update the student's absence sheet after I have done so. If you are close to your absences, you know you are, so I'm not going to beat you down about it. But if you pass the 3-day mark, also known as 24 hours of time, then you know the result of that. Kate, rename. Alejandra, are you here with us?
Alejandra.
Thank you, dear. Bailey. Blair.
Bailey.
Blair. Kanai. Caroline.
Caroline.
Clayton. Daniel.
Clayton.
Freeman.
Freeman.
Isabella. Jacob. Jake. Jonathan is here.
Jonathan.
Caitlin.
Caitlin.
Kate Stribling. Kelly Wang.
Kate.
Thank you, Kate. Kelly Wang. Kendall Bloss. Lauren Anthony.
Kendall.
Lauren. Thank you, Lauren. Martha. Matt, I know you're here. Matt Pierce. Megan Jones. Patty, I know you're here. Megan, I'm sure you're here. I'll check again. Tatum.
Tatum.
Rachel Mila Turner.
Rachel.
Thais.
Thais.
Thomas Allen.
Thomas Allen.
Thomas Catlett. Tiana Whitehead. Tori Fisher.
Tori.
Vanille.
Vanille.
Zach Bennett.
Zach Bennett.
All right. Share my screen so that you see the absences I have. Jacob Wynn is here, so I'll go back to that. Excuse me. Megan is here. Patty is here. Vanilla and Zach. All right, if you don't see your name with an X, it's because I don't see your name with an X. All right, I'm going to grab the chapters real quick.
You are now muted. You are now unmuted.
I don't know, Zach. I order stuff off of Prime every single day because I'm crazy. So I don't know what I will be getting for Prime, but I'm sure I'll get something. Multiple things. It goes for the whole day, doesn't it? Let me look. I'm gonna just go look right now. It's Prime Day. Oh yeah, I'm about to get a master test kit for my freshwater aquarium. That's normally $50, $21 today. God bless you, Zach. God bless you. Nitrate, yeah. It's a good one. Yeah, I'll be all over that. Boy, does Amazon know me. Hey, quit that. All right, let's get going with obstetrics and neonatal care, chapter 34.
You are now muted. You are now unmuted.
Make sure that I'm on all the right recordings and all the right things. I am. All right. Obviously, this chapter is about pregnant people who then have babies, and they sometimes do that in the EMS environment. So, we're going to talk about what normal pregnancy should look like, and we're going to talk about abnormal pregnancy, what delivery should look like, what delivery should not look like, and what becomes emergent. And we're going to discuss the fact that delivering babies is a BLS skill. It's not an ALS skill. There is a lot of, um, there are a lot of things that can go wrong that become ALS skills, but the delivery of a normal, healthy baby will occur with or without you. The chapter is going to discuss and drive home that we are not delivering babies, we're simply coaching. We're helping, encouraging, providing strong support for that mom to do what they're going to do already, even if you weren't there. So, our hope is that you are comfortable with the fact that delivery of babies is a natural process that does not require you to actually be present. And so that should give you some amount of comfort that having you there is even better. We're going to teach you what to look for that would give you more comfort, and we're going to teach you some things to look for that would say, this isn't a baby that we should be delivering in the field if we could help it. Let's get in the ambulance and get out of here. So that's the point of the chapter. Once that baby comes out, what is normal for babies when they first enter the world? What is abnormal for babies when they enter the world? What requires intervention and what requires us to leave the thing alone and let it do what it would have been doing if you were not there? So that's what we're going to discuss. A normal delivery is, as I described it, happens without you. Abnormal delivery potentials are nuchal cord, which means the cord's wrapped around the neck. Prolapse cord, which means you can see the cord come out before the baby comes out, which probably indicates a nuchal cord. Breech delivery is if anything but the head comes out first, so we're going to talk about that. We're going to go through the first, second, and the third trimesters, and we're going to talk about what that should look like. Specifically speaking about the third trimester, when we run into trouble, we're going to discuss placenta previa, which is not a huge deal, but is important, and that's where the uterus isn't connected correctly to the placenta, and so the placenta migrates itself down and causes a little bit of bleeding. Not a huge problem, but depending where the placenta is connected to the uterus, it may require the surgical removal of the baby rather than having the baby through natural birth. Abruptio placenta, on the other hand, in the third trimester or at any point in the pregnancy, first, second, or third trimester, would be the emergent and abrupt separation of the placenta from the uterus. And that obviously is an emergency. It would probably result in the death of the baby. It may result in the death of mom. So we're going to discuss that, why it happens, what we can do about it, if it happens, how to spot it, how to recognize it. When does it occur most? We're going to discuss those things. Spontaneous abortions, we're going to talk about, typical before the 20-week mark of pregnancy. Ectopic pregnancy, we're going to discuss as we have already in the course. That's just fertilization of a baby that begins to develop outside of the uterus. There's no supportive anatomy for that. So, if the baby is fertilized and implants in the incorrect place, if it's not in the uterus, there's not enough room, and so then it would cause probably rupture of the fallopian tube, which would lead to immediate bleeding into the abdomen. So, that's a surgical emergency. Preeclampsia is high blood pressure in pregnancy. Eclampsia is when that high blood pressure results in seizures in pregnancy. So we're going to learn about that. We'll learn how to assess a newborn. We'll learn how to care for a newborn, which again shouldn't require a ton of intervention if that baby is born healthy, happy, angry. When we say happy in the baby world, we mean angry. Angry babies let us know that they are perfusing. You can't be an angry baby if you don't have enough blood going to your brain, to your heart, to your lungs, to your kidneys. And so we like when they're upset. Trauma in pregnancy is pretty devastating. We should always, if someone says that they have a potential being pregnant or they are pregnant and they have been exposed to a traumatic mechanism, we should recommend a full assessment at a trauma center regardless of the outcome. Say they look fine, they're walking down the road. That's not enough. We should get that baby assessed to make sure there are no signs of distress that could result in emergency cesarean. Cesarean is where we surgically remove the baby instead of a vaginal delivery. You can have cesareans that occur in the hospital, and you can have cesareans that occur in the field, which is very rare. We don't tend to surgically remove babies from mamas in the field unless the mother is in cardiac arrest, and we believe that we are within 5 minutes of that arrest. If that baby is beyond the 28-week mark, there is a chance we could save the baby with an emergent cesarean. That is not something you will find copiously throughout the United States. It depends where you are, if you have a protocol for that. And there are agencies that do, and there are agencies that don't, especially flight agencies that do have those surgical intervention protocols. Should they be made available to a baby whose mom has suffered traumatic arrest, but the baby is within 5 minutes? We might be able to save that baby. Most cesareans, though, that is certainly the exception that I just described. Most cesareans are performed by physicians, and most commonly they're performed by OB physicians. Emergency room doctors do not do very much care of the OB patient, even in the case of an emergency that will be referred to the obstetrics physician. The same is true for EMS. We try to address the most emergent things about obstetrics, but we too are not specialists in this genre, so we would defer to the OB specialists. So what does EMS look like if you're an OB specialist? It looks like HIROB. So there's an EMS specialty called High Risk Obstetrics Care in the field, and that's pretty rare, but most of your states have a flight service or two that is HIROB. So in the state of South Carolina, the only HIROB base I know of is our base at Medicare Air. There might be one in Colombia. I don't think they're running a high rod program, but maybe they might be. So that's not very common. We tend to stick to the most emergent things, and so we'll talk about those. Most deliveries do occur in a hospital still, but you also need to be aware that mothers are increasingly having their babies at home. Things change with tide of turning, and they tend to go in a circular fashion. What we used to do, we find out we don't like that, so we stop doing it, and then eventually we like it again and we start doing it again. And that is definitely the case, it seems, with having deliveries at home. Is there anything wrong with delivery at home? Well, with well educated, very informed, and prenatal care analysis, no, there is nothing wrong with having your baby at home if this baby is projected to be a happy, healthy delivery. Then the statistics might even lean towards favorability of having that child at home. We know that American medicine is not doing very well with obstetrics. We have one of the highest fetal mortality rates of any advanced country in the world, if we don't currently have the highest, which is very odd considering that we are one of the most advanced medicine countries in the world. We carry that baggage of fetal mortality around with us because we live in a medical society in America that is built from profit. When you're built from profit, you can't spend as much time with the patient. When you're built from profit, you can't have as much exposure to the physician. You have a lot more exposure to nurses, to medics, to other care providers beyond the physician. We also see a rushing of the natural process in American medicine, where we are trying to speed along the delivery of babies, mostly to suit the preferences of obstetrics physicians. When I've done my clinicals, when I have spoken to the folks who specialize in delivering babies at home versus the folks who specialize in delivering babies in the hospital, there is a stark contrast between the two mentalities of those individuals. So if you're delivering babies at home, you're probably a midwife. In the state of South Carolina, you can go as a nurse or as other types of providers and get certified as a midwife. And you can specialize in delivering babies at home should parents want the delivery of a baby at home to be assisted by a midwife. You could potentially do it all by yourself, which is kind of crazy, but you could. Why is that important to you? Because you might be responding to a scenario that was meant to deliver at home but didn't go well. So you need to be prepared for that scenario. We have a lot of births that are tub births, which are they're delivered into water, which is not a big deal. But if it goes poorly and people freak out, it could become a big deal. So these are things you kind of need to have in the back of your head. You might be dealing with a family who's delivering a baby at home. You might be dealing with a baby that was projected to be a happy, healthy delivery, but it is not now a happy, healthy delivery. And so then you might need to resuscitate the baby. You might need to deal with bleeding from mom that was unexpected and isn't stopping. Another reason we might contact a patient who was delivering at home. But nonetheless, deliveries do happen at home, and they do happen at home very well. Most of them go without incident. Most of those babies are happy, healthy, good to go babies, and the statistics might even say that those babies are less likely to develop healthcare environment acquired infections. They're less likely to have separation anxiety. There are tons of data that might suggest one over the other. So know that that is happening out there. Of course, if you found a baby in distress, you would treat the baby the best you can in your A, B, and C's and emergently transport that baby, hoping for ALS backup. But if not, do the best that you can until you get to a hospital. I do want to touch on one important part. Never ever should we be so focused in getting to a hospital that we negate the treatment of bleeding control, life threats A, B, or C. If you are even transporting to the hospital, but you have now run into a scenario where there is an emergent threat to A, B, or C. You need to stop moving towards the hospital and put your resources and your attention and your efforts towards your primary. You need to understand that the primary assessment is moving. And at any moment, your encounter with the patient might find you back in the primary. So just because we have done one and we have moved on from it and we are now solidly in the secondary does not mean that the patient might not change in a way that would require you to go back to the primary. You can't keep traveling towards the hospital, negating the care of life threats, and expect to arrive there with an alive patient. So please keep that in mind. Reaching the hospital is never as important as maintaining ABCs and life threats that you can maintain. If the problem that they're experiencing, the emergency that they're experiencing, is not something you can solve, then by all means, you have got to get to the hospital. That becomes precedent. That is what is of most concern. Your paramount decisions should go towards that. But normally that isn't the case. Normally we see a patient who has an acute change and we forget about the primary in our efforts to get to the hospital. Don't get caught up in that. Getting to the hospital with a dead patient isn't as good as getting to the hospital with a patient whom you still have alive because you have appropriately addressed the primary assessment. Okay? Let's get into a little bit of anatomy and physiology of our female patient. Again, obviously we have two ovaries. They release the eggs. The eggs travel down the fallopian tubes. The fallopian tubes, then if the egg is fertilized by sperm, gets to the uterus, and the egg implants, the fertilized egg implants into the uterus, and then we would have pregnancy. That would begin to develop. So if you don't get that process, make sure you do some reading. Pretty easy. The labor process itself starts with contractions. It will also include eventually breaking of the amniotic sac, which is the water-filled sac that holds the baby. The cervix, which we've talked about before, which is the gatekeeper of the uterus that leads to the vagina, it will efface and it will dilate. The word dilate means to open, and the word efface means to thin and become very malleable, very pliable, which is what allows it to open and allows the baby then to progress through the birthing canal. So make sure you understand that process. Make sure you understand the anatomy of your female patient, because if you don't, it's going to be pretty difficult to treat them. This is a perfect case scenario on slide 34-1, where you have the placenta, which is the nutrition / perfusion sac that attaches to the uterine wall. And so if it did what it was supposed to do, it's probably up here on the top. Okay. It's creating a fundus, which is the most hard, healthy, squeezable, strong muscle at the top. So you might get asked, what is the fundus? Well, the fundus is the very top of the uterus, and it is the strength of the uterus. When you talk about squeezing a baby out, that strength is going to come initially from the fundus. You can always palpate the fundus. You can feel the fundus, and the fundus rises in the abdomen of a gestational mother based on weeks of pregnancy. Example, at about 20 weeks, the fundus tends to be periumbilical or around the umbilicus. So this is something we can palpate in the field, and it is something we can assess. It's also something you're going to come to learn later. You might need to massage in order to treat for postpartum hemorrhage. Postpartum would be after delivery. Hemorrhage. If we massage the fundus, it releases oxytocin, and oxytocin causes vasoconstriction, and vasoconstriction reduces blood flow. So we might actually be finding the fundus after delivery to massage it for that purpose. After the baby is developing in this amniotic sac here, there's an umbilical cord going from the placenta to the baby. Now, remember, I'm teaching you based on the idea that you know nothing. So if you know some of this, great. But what I have found is that most people think they know way more about this process than they actually do know. So I'm just going to go through it piece by piece. The umbilical cord does attach to the placenta, and the umbilical cord then attaches to the baby in the umbilicus, which is your belly button. It's delivering oxygen and nutrients and blood flow via one artery and two veins. You might get a question that asks you about fetal blood flow, and it might ask you about placental based blood flow. How is the baby receiving nutrition and blood from the mom? The answer is placenta to umbilicus, the umbilicus to the baby, and the umbilicus carries one big artery and two veins. So you got to keep why is that playing? You got to keep that circulation kind of in mind. Later on, we're going to talk about as I have already discussed, we're going to talk about two ways that the placenta can act a fool and cause us a little bit of trouble. So, I think I said something wrong, so I got to go back and tell you again. The umbilicus carries two arteries, one vein. I was going a little bit too fast. So I was about to tell you how to cannulate that vein, but then I remembered you're an EMT class and not paramedic class, so we don't cannulate umbilical vein in the BLS world. So I will focus on EMT class now. There are two arteries, one vein, and that vein can be accessed by a paramedic depending what state you're in to give the baby resuscitation, because as you might realize, it's pretty difficult to get IV established on a baby. And even IO. We do IOs on neonates, but their bones aren't very developed, and so it's easy to overshoot an IO access on a baby. So we tend to want to access the umbilical vein for that, and I'm going to teach you later how to cut the cord so that you have prepped this baby for the best potential access via the umbilical vein. The baby is normally upside down, but is moving about in the belly. They can be kicking and moving, and as they develop and grow, they get more happy and excited, and they're kind of developing a little bit more motor function, and so they're going to kind of be swimming about all over the place, which, as you might imagine, puts a lot of stress on mom's organs. Very difficult to sleep towards the third trimester. It's kind of difficult to go to the bathroom in the third trimester because all of that weight is pressing down on the bladder, pressing down on the urethra, pressing down on the colon. So pregnant women in the third trimester do run into a lot of complications just in the natural development of that baby's anatomy versus the natural anatomy of the mom. So you have that. You have the amniotic sac surrounding the baby, which is this clear yellowish fluid, and there's amniotic fluid in there. That should be really clear, really clean, very kind of yellow tinged. What it should not be is like a green slash brown slash black fluid. That would indicate that the baby has released fecal matter into the amniotic sac, and we'll talk about that later as to what that means. It's called meconium staining. You have the vagina that comes past the cervix here. The cervix is the gatekeeper. Then you go into the vagina, and the vagina would then come out to the opening, to the rest of the world. So know that anatomy. You're going to get simple questions like, what is the most outer portion of the anatomy of a female? And that would be the vagina. Here is another picture of that anatomy. Here you go. It tells you that you have oxygenated blood. The umbilical vein carries oxygenated blood from the placenta to the fetus, and the umbilical arteries carry deoxygenated blood from the fetus to the placenta, which is odd, right? It's in reverse, but it's not really because it's still following the same rules. Arteries carry blood away, and veins carry blood back too. So it's still following the rules, but it's in reverse of your general thought process with the adult patient or the developed post-fetal patient. So in this case, it's a little bit in reverse. The umbilical vein is carrying oxygenated blood from the placenta to the fetus, and then the umbilical arteries carry deoxygenated blood away from the fetus because arteries carry blood away. There's your half a liter to a liter of amniotic fluid. And typically that will rupture when mom goes into labor. So that's a good process for us to see and check, has that happened? Because if it has, we're more likely to encounter labor. You can deliver a baby with the sac not breaking, and we would then have to break it ourselves. And so we'll talk about that in a little bit. But basically, you just break it as carefully as you can. We try not to use objects, but if you are going to use an object to break it, because it is a pretty tough little sac, you then need to use a blunt object. Definitely nothing super sharp, definitely nothing that is very pointed, because you might rupture the sac, which would result in an immediate access to the baby and then stab the baby in the head. That would be bad. So you want a blunt object if possible. But we might have to rupture it ourselves. If the sac were to present first and mom is pushing, you're getting a baby, you need to rupture that sac and get it out of the way. That is a BLS potential skill, depending on your protocols. Because again, that's a natural process that needs to occur that didn't, so we would just make it happen. You need to know that in pregnancy, we go up pretty much in all things. We go up in blood volume, we go up in breathing rate, we go up in heart rate, we go up in blood pressure as a norm of pregnancy. Obviously, their hormones also change, as we hear people talking about and making fun of. And so there's a lot of mood change that goes along with pregnancy. The speed in which they clot speeds up, so that can lead in some abnormalities to increased chances of blood clotting that goes to the brain and heart and lungs. That would be bad. Increase of 20% heart rate. You're going to see some test questions that ask you about the hemodynamic changes that occur during pregnancy. So be ready to answer for that. Weight gain, of course, is very normal for the patient. But depending how much weight they gain, depending how much their blood pressure increases, we might run into gestational diabetes and gestational hypertension. And gestational hypertension, which we're going to call preeclampsia. So if you get gestational diabetes, that increases the chances that the baby will have problems upon delivery. If you get preeclampsia, that increases the chances that the baby will present with problems upon delivery. So basically, any abnormality that starts occurring during pregnancy starts to increase the chances that the baby won't come out doing well. So we need to assess a good sample and a good OPQRST on pregnant patients that we're treating. When were you due? When are you due? Who is your prenatal care provider? Have you been receiving prenatal care? In your prenatal care, have you been a diabetic? In your prenatal care, have you been preeclamptic? Are you receiving any therapies for that? Have you used any drugs or alcohol during this pregnancy? Have you smoked during this pregnancy? Have you ever been placed on bed rest during this pregnancy? Those are the things we want to ask our gestational patients so that we are judging whether or not this is going to go well for us in the field. With pregnancy, you're always kind of using statistics and data to tell you how much work you're going to have to do should this baby try to present in the field. So if it is the case that the prenatal care has been pretty poor, if the pregnancy has been high risk, there's been too much weight gain, there's been retention of fluid, there's been diabetes, there's been high blood pressure, there's even probably been seizures related to that high blood pressure, then that is a pregnancy I wouldn't want to deliver in the field. Drugs and alcohol and smoking is a pregnancy you wouldn't want to deliver in the field. excuse me, will you always get the opportunity to not have to deliver those patients in the field? No. But if you could, you would try to get that patient to the hospital. When drugs, alcohol, and smoking are used during pregnancy, they cause intrauterine growth development restriction. Basically, the fetus doesn't get to develop at the rate of week mark that we expect. There might be a slowing in that development. So, say this baby is born at the 38-week mark. Well, that 38-week mark for this particular fetus, if there's been drugs, alcohol, and smoking on board, might actually be more like the development of the 32nd week. So now we have a baby who doesn't want to breathe on their own. Now we have a baby who doesn't want to clear their own airway. So drugs and alcohol, smoking and drinking, drugs during pregnancy, that tends to restrict the growth of the fetus, which then presents challenges for delivery. That baby's going to need support. So be careful with that. I was going to tell you something specific, but I'm going to hold on to them. A few, Jonathan. Paramedics have to deliver a certain amount of babies in order to even get out of school. So, a few. I have not delivered a single one that was in trouble. So most of these go well. I've had some that delivered before I got there that were in trouble. But any delivery that I've been involved in, thank God, knock on wood, that baby was well. So that, I got lucky. A lot of people do have stories that haunt them about this. I don't, thank God. There are also medics and EMTs that tend to just get pregnancies for whatever reason. They just tend to get a lot of this. I don't. I do get a lot of airway stuff, but I don't get a lot of deliveries in the field. So if you get one, you're kind of lucky. Let's talk about para, gravita, and abortio. So we were just discussing that your sample and your OPQRST needs to account for whether there has or hasn't been prenatal care. Who is your prenatal doctor? When were you due? When are you supposed to have this baby? How many weeks are you along? We know that you're supposed to be 40 weeks along before you deliver a baby. That is the best time in the oven. That's what we say. 40 weeks is our happy place. But we know that anything after 28 weeks might be viable. Anything before 28 weeks probably won't be able to breathe on its own because lung development tends to occur in the 27, 28 week mark. We're talking about lungs that want to work on their own. So if you found a baby delivered at the 22nd week and it looks super, super alienish and it's not very developed and it's not breathing, there are no detectable pulses, you wouldn't try to resuscitate that baby. It's not viable. It doesn't have the organs necessary to sustain life. So you need to remember these week marks. 40 weeks is the best timing for you to be in the oven. 28 weeks and after, we believe that the lungs are developed enough to try to start breathing on their own should that baby present now. Anything after 32 weeks, we're happy with. Okay. And you're going to see in the test questions that anything after 42 is bad. Okay? So 28 weeks and before, bad. Once you start passing the 40-week mark, bad. And then the 42 is where we know that we should get that baby. If the baby's in the oven too long, it also runs into pretty big trouble. So remember that. We'll see a slide more specific to that in just a second. All right, let's go into para and gravita. So how far along are you? When are you due? Who is your prenatal care provider? Have you been getting prenatal care? How's it been going? Those are the questions you want to ask to try to predict the outcome of this delivery should it occur in the field. We're going to also ask how many pregnancies have you had? That's gravida. How many live births have you had? That's para. And how many spontaneous abortions have you had? Basically, your body decided to cancel the pregnancy. You hear people say they've miscarried. That's what a spontaneous abortion is. It tends to happen before the 20-week mark. It can happen at any time during a pregnancy, which is obviously devastating to new parents. So, how do you remember grava and para? I remember that para equals parent. So, if it came out alive, you're probably still the parent of that child, accepting that anything horrible has happened. You're probably still the parent of that child. So, if I was para 2, so P2G3, then I'm probably pregnant, unless I am A1. That's how you're going to hear us talk. We're going to say, hey guys, how are you? I've got a 32-weeker here who is P2G3. We're A1. And there's vaginal bleeding. You'll hear us talk like that. And what that does is it predicts things for you. So para is how many babies have you had? And that would be 2 in this case, and then 3 pregnancies. And so if we take out the A1 and we're just P2G3, I'm happy as a peach because that means the mom is pregnant and they've had 2 babies. They were live birth babies because we can't count stillborns. P doesn't count stillborns. So then we would talk about this third G that they have. How's it been going? So you also can judge how fast delivery is going to occur. If they are P0, G1, what do you think that means? What does that mean? This is the first time pregnant. So if mom's amniotic sac ruptures in the field and contractions begin, and they're organized and they're consistent and they are shortening in duration from one to another, you can take your time because the first pregnancy can go on for days, not hours. So everyone that's running down the road emergent with a patient in labor who is P0G1, I'm laughing at you because you are dumb. You did not read the book. Now, is that a guarantee? No, but most commonly that is the case. Their body doesn't know, that mama's body, who is G1, doesn't know how to deal with labor, and so it has to learn it, and it has to go through those processes a little slower. Now, if you are looking at this, and mama's amniotic sac ruptures, get ready to catch. Because if those P's have been vaginal births, you about to get that baby quickly. We call that lightning delivery. Lightning delivery is typical of a high P gestational patient. Once you start having some babies by vaginal birth, the body is very accustomed to that process and it learns it very well. And the muscles are more positioned to do their job very efficiently. And so the babies after P1, P2, P3, those babies are going to come much faster than P1 came. Sufficing that, again, they were vaginal deliveries, which they probably were, depending where you are in the country and if the obstetrics doctor needed to get back to the golf course fast enough. Most likely they were vaginal births because that's what we would hope for. So make sure you understand grava and para. We use grava and para to tell us a lot about the previous pregnancies, How did they go? Were they successful? We use Grava and Para to tell us how fast this baby is likely to deliver. Although you can take none of these things as a rule, they are all just considerations. Okay? So make sure you understand para and gravida, and make sure you understand abortio, because if they've had 3 spontaneous abortions, so if they are G3, if they're G4A3, that's a pretty risky patient. Those patients are probably on bed rest. For whatever reason, that mom has difficulty producing live birth. So it would be important to know that they are G3 A2. That means they've had 2 spontaneous abortions prior, and they've had 1 pregnancy that's ongoing. Those abortions can also be elective. They don't have to be spontaneous. Elective abortions, depending what data you're looking at, also do increase risk. Although there is no data to suggest that elective abortions will cause a mom to not be able to have a successful pregnancy and live birth, there is data that might suggest an increase in risk. And so we do still account for elective abortions, just not weighted as much as we account for spontaneous abortions. If there are any questions, do speak up. We've talked about preeclampsia. That's high blood pressure in the in the presence of pregnancy, which is called gestation. Typical to develop early. Okay, we remember that we have 3 trimesters, so 3 months apiece. That's 12 weeks. So you're into the 2nd trimester when you develop significant enough preeclampsia to start worrying us, to start putting people on bed rest, to start altering their diet, to start maybe even looking at medications and pharmacological therapies. So when you see the week mark of gestation, make sure you can start making your brain turn that into a trimester mark. Okay, if someone tells you I'm 30 weeks, you need to be able to realize that that is your 3rd trimester. No, it does count the current, Zach. It does count the current. So if I'm currently pregnant and I've had 2 children, then I am P2 G3. It wouldn't be relevant if we weren't talking about a pregnant patient. We wouldn't be even asking para, gravida, and abortio if we weren't speaking of a pregnant patient. This relates specifically to gestational patients. What if you're P2G3A1? Does that mean? Well, you wouldn't really be talking about that. That can be true of a patient, but it wouldn't be relevant. So the example that I used above is just to show you how it works. You wouldn't go into the hospital and be like, hey, I got a 22-year-old female complaining of chest pain. The patient has no cardiac history, no respiratory history. By the way, she is G3P2A1, no pregnancies in the last 2 years. You wouldn't include that in their history unless it were relevant. So if this patient had significant vaginal bleeding, if this patient thought that maybe they had miscarried again, then that would become relevant. But if it's not referencing OB/GYN care, it wouldn't be included in a person's history. Does that make sense? Okay. So make sure you understand preeclampsia. Eclampsia is when it gets dangerous. That's when we're potentially going to lose mom, and if we lose mom, we lose baby. By the way, that brings me up to the conversation of you need to realize that there's a lot of people who want to know how the baby's doing. And that is important. And the more you go towards ALS care, the more you go towards critical care, being able to assess the fetus is important. But on a general basis, in an emergency scenario, if you can save mama, you will most likely save baby. So I want you to consider that when you're thinking so deeply, I wonder how baby's doing. Well, baby is doing as well as mom is doing. in most emergencies. So focus on taking great care of mama, and it is likely that you're then taking great care of baby. And that just makes sense, but I feel like people get lost sometimes when they're really wondering how that baby's doing, and you don't have a lot of technology available to you at the BLS level to really know how that baby is doing. So just consider that. Keep that in the back of your mind. If I take good care of mama, I'm taking good care of baby. If you were to go from preeclampsia to eclampsia, then we need to deal with the seizure as an airway concern. So the same stuff you would have done for seizures without pregnancy is what you're going to do for seizures in the presence of pregnancy. Get them on their left side, maintain a good airway control, maintain oxygenation, clear that airway if needed, get that BGL because seizures tend to produce a low blood sugar, get a temperature, seizures can produce hyperthermia. So get ALS back up and then emergently transport the patient. That's the same stuff you would have been doing for seizures before. You just happen to know that this seizure is likely caused by high blood pressure in the presence of gestation. Remember that the problem is still an airway problem. The seizing that you see externally, although distracting and maybe even traumatic for you, those are not the gross concerns. Airway is our concern. Are they breathing? Are they oxygenating? We need to maintain that component the best that we can. Why lay the patient on the left side? I'm going to ask you as a class that question again. You should know the answer by now, but it's even more important in pregnancy patients that we always favor the left side if we're going into recovery position or if we need to place the patient in some type of supine position. You can't put a heavy gravida mom on their back. You can't put a third trimester mom on their back. Why not? Well, Thais, that is not a wrong answer. It does make breathing hard. It makes it more difficult to breathe. But the more emergent answer is that when we get into the third trimester, we talked about that baby being large enough in size to push down on the anatomy. And it does the same with the great vessels. Once that baby is big enough, it's developed enough, if you lay mom on their back, that baby is going to rest on top of the vena cava. And so then the vena cava is not going to return blood flow to the heart. No, it will not wrap the cord around the baby's neck in utero. You will stop mom from receiving blood to her heart. And if she can't put blood in the heart, she can't put blood out of the heart. We call that supine hypotensive syndrome, which is going to be a test question in this chapter. But we've already discussed that. We've already said that obese patients, late trimester gravida patients, gravida means pregnancy, those patients can't go on their back. And it is true, Thais, that those patients also experience difficulty breathing because of the same exact reasoning. You're putting pressure on the diaphragm, you're putting pressure on the lungs themselves, and so then it's more difficult to take a breath. But what may be more difficult to see visually as your understanding of anatomy and physiology is that bigger problem of pressing the vena cava closed. We know that the aorta is under pressure. So it's hard to press the aorta closed. If you got a little pressure on the aorta, it's going to overcome that pressure. But the vena cava is not under high pressure. It is venous, it's not arterial. And so it is really easy to press the vena cava closed. Especially if we're talking about late gravida moms. So, as you might already know from any experience you have with a pregnant family member, once they get to that late second third trimester period, they don't lay on their back anymore. They need a lot more pillows. If you're sitting upright in semi-Fowler's position, you're happier because the baby is being pulled down and not on the diaphragm, not on the vena cava. If you're laying on your left side, you're happy. They even make pregnancy late trimester pillows that kind of form themselves to the female anatomy of a late gravida patient. That is all for this purpose. This understanding that you cannot lay late trimester patients on their back. Why is that important in eclampsia? Well, we know that pre-eclampsia probably began in the second trimester. It advances and becomes emergent in the late second, early third trimester. And so if we're in the late trimesters, then I'm a big mama and you can't put me on my back. That's how that understanding should work for you. Supine hypotensive syndrome is the idea of pressing the vena cava closed with the developing fetus, and now mom is super low in blood pressure, super unconscious, and you're scrambling thinking, what's wrong? What's wrong? What's wrong? You got her on her back. And if she's on her back, she can't put out blood flow. She can't get a good blood pressure. If you don't have a good blood pressure, you're not perfusing the brain. So she's going to become unconscious pretty quickly. Turn mamas on their left side. Okie dokie. Let's talk about CPR of a pregnant mom. The same is true. You can do all the compressions you want, but if that baby is laying on the vena cava, your compressions aren't working. So how could you do CPR on a pregnant mom? Anybody? Kate is correct. You can manually displace the fundus. Finding the fundus, the hard top portion of the developing uterine wall into the developing fetus, that's the fundus. We could manually displace it to the left. But that's not as good and maybe even more dangerous than placing the patient in an appropriate position for transport and CPR. Can anyone come up with a good idea of how you would maintain CPR and not incur supine hypotensive syndrome beyond just manually displacing? So very good, Zach. You could put a Lucas on the patient and then turn the patient on their left side, although turning all the way to the left is a bit much. So what you could do is place the patient on a supine board. Place the patient on a long spine board. Secure the patient. Then tilt the patient just left, which will do exactly what Kate was saying we could do manually. If you push that patient just a little tilted to the left, maybe even 30 degrees, maybe 45 degrees, tilted left, put some bags that you're not using underneath it. So we always have a couple bags for EMS stuff that don't apply to this particular call. You could stuff those underneath the board. And now I have a patient who is leaning left and getting all of that anatomy off of the vena cava so that my compressions are still effective in depth, in rate, in recoil, but they're not lost on a compressed vena cava. Everybody understand that? And yes, Zach, using the Lucas for this purpose, if it is successful, and it probably will be because the Lucas is a very solidly designed device, doing so would be successful if you tilted that patient just a little bit left. Zach knows about the Lucas because we played with it at the flight ride along that he did. You can also, I think that was Zach. I think so. Yeah, I think it was Zach. That wasn't me. Okay, that wasn't you. That was Vanille. It was Vanille. So Vanille got to play with that. And I showed you guys a video of it on GroupMe. So if you didn't see that video, one, you're not paying attention to GroupMe. And two, it's on there. You can go see the Lucas working. And the Lucas clips into metal holders on a backboard. not the metal holders that are on the actual backboard, but it comes with its own little backboard and it clips into those. So you could tilt that patient 360 degrees and it is still going to do its job. So that's a pretty good device. I'll screen share with you real quick and kind of let you see what we're talking about here as a visual. This bad boy.
The same protocols as for manual CPR. Lucas allows for effective compressions during patient transport and safety for both the patient and personnel. Now let's step through the basics of how to use it. The basic steps for using Lucas are: arrive, confirm cardiac arrest, and start manual CPR. Unpack Lucas and power it on. Assemble Lucas on the patient. Adjust and operate Lucas. Defibrillate. Then the patient. If you arrive and the patient already has pads on, you might need to replace them or reorient them.
So that right there is the backboard that it comes with, this little yellow thing on the bottom of the patient. And if you were able to put that on a spine board and then tilt the pregnant patient to the left, you'd be pretty effective in doing CPR. I do prefer Lucas over Autopulse. Lucas is faster to apply. Lucas is non-migratory. It doesn't tend to move itself down the patient if you use the shoulder and neck strap. It's also a click and go device. Matt, you've seen the Autopulse deployed a lot, and you know firsthand that it takes a lot to manipulate the patient and get the Autopulse underneath the patient. Is one device better than the other? The data would say no, that's not true. Is one device more user-friendly than the other? I'm arguing yes. If you're in a helicopter, you might see them using Autopulse more because the Autopulse is a flat device. It doesn't have that long-standing. If you look at the Lucas, this stands up pretty high versus in the Zoll Autopulse, it is like a little backboard and it's flat. And so you don't have that long...
Get ready for your summer road trip at Advance. 5 quarts of Mobile One, Castrol, Valvoline, Pennzoil.
It's not super high. So helicopters don't have a lot of headroom, and so then they might use the Autopulse. At my base, we use the Lucas because we have enough room for what we're doing. Let's see if they're doing compressions.
You hit the continue button to remind you that there are no compressions going on at this time. It's beeping as I'm talking. Now we have a continuous compressions mode. Now let's say we need to stop compressions again.
The Autopulse band goes down lower than you would imagine, right? But thankfully they have this little shoulder line here to help you understand whether or not you're in a good place. Because it's compressing from the rib line, trying to get a circumferential compression. So it works a little differently than actual CPR. The Lucas device is more like your CPR. So, you know, Matt, certainly I don't endorse one over the other, but if I were able to choose, I would choose a Lucas. It's been nicer to me. It's easier, I think, to work, provided that you use it the way it's designed. The Autopulse is finicky. If you interrupt the life band any way, then it's going to air out and stop, because it's more dangerous for it to continue not knowing if it's in good placement than it is to just stop and make you do manual compressions. There is no data to suggest that these automated devices are better than manual compressions, but there is certainly a lot of data to suggest if we're moving the patient, they are better than us at that, because you can't do good compressions on the go. But the device can. The device doesn't get tired. The device doesn't interrupt. So it will do better than you. If we're talking about getting to the truck, if we're talking about going down the road in an ambulance, the device is going to do better than you and I. So if you have an automated device, that is good. That's better. I would also say, Matt, if you want the device to be nicer to you, start rolling the patient onto their side versus trying to pick the patient up and slide the Autopulse underneath it. Every time I've seen that used in this particular area that you and I are working, people tend to be trying to pick the patient up and put it on. We need to be rolling the patient onto the Autopulse. That is an easier method. That just takes training and prepping and planning. So we talked about preeclampsia, talked about eclampsia. Make sure you know the difference between the two. Vaginal bleeding more than 500 cc's is an emergency, and that's a test question. In placenta previa, you have a characteristic of minimal to no pain earlier in the trimesters, and spotty bleeding, vaginal bleeding with no pain. That would scream placenta previa. Listen to me. Vaginal bleeding earlier in trimesters, minimal to no pain, that would be placenta previa like. Abrupt bleeding with a lot of pain, especially related to any trauma mechanism, would be more like placenta abruptio. Okay? Abruptio is pretty clear that you abruptly came away from the uterine wall, and so then you have a bleeding baby who's not perfusing, by the way. More common before the 20-week mark. I'll let you read that. Know that we do have to Narcan babies sometimes. We do have to Narcan babies. If mom was on a medication that would make mom's breathing and consciousness decline, then it's likely that the baby's breathing and consciousness has declined. Let's take a break. Let's come back at 9:30. 9:30.
You are now muted. You are now unmuted.
All right, everyone. We'll get back into it. Everyone can raise their hands. Thank you, Clayton. Bailey, waiting on you. Megan, Michael, Patty, Tatum, Zach Bennett. Tatum Duke, where you at? Oh, Tate. Where is Tatum Duke? Put on a 5-minute timer to check Tatum Duke's attendance.
5 minutes. Counting down.
Thank you, Mikey Mike, Patty Pat. Moving on. All right. Remember, with trauma, you do have 2 patients, but again, I want to tell you to focus on mama, then you'll treat baby well. If you have any trouble with mama as far as spine goes, you can always place mama in a KD. as well. Now, clearly, you can't use the KD straps very tight. I'll remind you what a KD is because I don't want you guys hearing me say things and then remaining quiet when you have no idea what I'm talking about. But remember that the KED is the spine board for sitting patients. So you can place a patient on a spine board that is seated. So it goes from head and neck to butt. And so you can put this patient in semi-Fowler's position. Semi-Fowler's position also helps to protect from supine hypotensive syndrome. So you can put a patient in the KD instead of putting them on a long spine board. If you feel that it is indicated and not contraindicated, you could do that based on wherever your protocols or guidelines put you with that particular scenario. Be of high suspicion with trauma because they have higher heart rates at baseline. They have higher blood pressure at baseline. They have higher breathing rates at baseline. So it's more difficult for you to tell if you're seeing a compensatory mechanism or if you're seeing a patient who's just breathing their normal rates. So since you can't tell, then your index of suspicion has to err in favor of the patient. That is why I said earlier, just have all patients who are pregnant and who have been exposed to any amount of trauma mechanism, you should recommend that they go to the hospital. Even when I go to bumper MVAs and I talk to the pregnant person on scene and they're like, I think I'm fine. They just kind of tapped us. I don't take any chances. I always say a pregnancy can hide traumatic bleeding. I think you should get checked out. If you don't want to get checked out, you'll need to sign a refusal. I don't ever do a no need on pregnant people, ever. If something goes wrong with that baby, they will blame you all day. They will take no personal assessment of their own decisions. They will blame you. So you got to err on the side of caution there and always recommend that they should be checked out, even if the mechanism was kind of small. We already talked about CPR. Cultural sensitivity I'll let you deal with, but clearly pregnancies, dealing with vaginas, who can see it, who shouldn't, whether people are okay with nudity or aren't okay with nudity, whether a man wants another man to deliver his baby, all of that, what I think is superficial crap, goes into the scenario. But it is real. People do have these thoughts, these considerations, and so we should, as providers, do our best to meet the patient's cultural needs. I know when I was in paramedic school, it took quite some talking. There was a Middle Eastern family in my clinical rotation, and they were having a baby or two, twins. And the husband at first was pretty adamant that he did not want me in the room because I was a man. And then there was, some talking and rationalizing, and that person ended up being okay. And they were very nice and very, including in that clinical rotation. And so I was very thankful. But it was something that concerned him because in their culture, more specifically in their religion, there are talking points, there are contention points about other men versus spouses. So you got to be careful with that. you gotta be willing to kind of go there if you have to go there. Teenage pregnancy, what I'll just say is once a teenager is pregnant, they do have rights over their unborn child. And so some legalities I'll just touch on is you don't necessarily have the right to tell parents that a teenager is pregnant. So you got to be kind of careful with that. Just because someone is someone's parent doesn't make them automatically entitled legally to all the information. So be careful with that. You should also know that childbirth is mandatory reporting. You cannot keep the birth of a child secret. It is a felony to do so in most places. So you've got to make sure that people don't have babies at home and then going about their business. That has to be reported. That has to be accounted for via a birth certificate, which is a natural thing to do. But there are people out there who don't report it. There are also people out there who don't report it for criminal intent. So just make sure you understand that. Tate, can you put your hand up in the air and wave it like you just don't care? Watch this. All right. If I can't confirm you're in here, I'll kick you out of the session, and then when you come back in, I'll account for the time from there to the re-entry. Tate, with a T for Tom, or Tango, or Tilapia. Sorry. You would already know, Kate, because you wouldn't have been able to send that message. All right, all right. We already talked about all of that. Let's get into my favorite part. The delivery of the baby. So we talked about the growth, the physiology, the anatomy, the mama versus the baby, trimesters. There should be 3. They're 3 months along. 40 weeks is the happy spot. 28 is the beginning, and anything before that is bad. 42 is too long in the oven. So we talked about the normal gestational period. Okay? We talked about some of the things that go wrong in gestation. Well, let's switch over to we're going to deliver this baby in the field. So the stages of labor are going to be on the test, and so you've got to remember them. The first stage of labor, and it's not as easy as it looks here on the slide either. The stages are moving. So the beginning of one stage is the end of another. You'll have to read the question closely to know what they're trying to ask you. What period in the labor process are they talking about? So stage 1 is dilation to the cervix, which ends with 10 centimeters of dilation and the presenting of the baby, which we call crowning. Crowning can be vaginal bulging, or crowning can actually be you able to see the head of the baby through the vaginal labia. So stage 1, dilation to crowning. Stage 2 is crowning to delivery. The baby is all the way out. Stage 3 is the baby is now out all the way to the delivery of the placenta. So make sure you understand the stages of labor. Why do we need to understand the stages of labor beyond test questions? Well, 1, there could be more than one baby in there. Make sure you understand that. There could be more than one baby under there. 940. Okay, I'm going to put you in, Blair. Lecture. There could be more than one baby in there, so that's really important. Another reason is if you don't have delivery of the placenta, that's a pretty big deal. Probably every one of you had thought about how babies come out, but probably pretty few of you have thought about the fact that you also deliver the placenta. It doesn't just stay in there and get absorbed. It gets delivered just like the baby did. So you've got to kind of remember that. It should be about 15 minutes or less for delivery of the placenta. So the baby comes out in probably 15 minutes or less, you should have the placenta. You need to inspect the placenta and make sure that it doesn't look jagged or that it's been traumatized. If there are pieces of the placenta that stay inside mom, those become pretty big infectious risks. They also become bleeding risks. So if the placenta fragments, then it can bleed pretty bad and it can also cause infection. So that's why we've got to understand those stages. Understanding false labor versus true labor. I would say this to you. You shouldn't care because it is not easy to detect whether something is Braxton Hicks contractions or whether something is true labor. That's not true. It is easy. However, patients don't follow the rules. So Braxton Hicks can be mislabeled. It should be diagnosed by a physician, not by EMS. If a person says they think they're in labor, we just need to take them at their word for it. But we need to discipline that with understanding of how true labor works. Once contractions start, they get stronger and shorter in duration. And when I say duration, I should say frequency. Frequency would be a more appropriate word than duration. I'm going to change that. Because duration is how long the contraction lasts. Frequency is how far apart they are. So if labor is true, in most circumstances, ooh, that's some sweet crepe. I would have gone with Italian, but whatever. It's fine. If labor is true, contractions start, they're pretty mild. They last for a minute, maybe less, and then they go longer as you progress, but more in frequency. They become stronger and more aggressive, and they become more frequent, the duration between them. So you might have started at one contraction every 10 to 15 minutes, and now we're at one contraction every 3 minutes. Well, that is true labor, that's progressive labor, and I'd be really concerned about that. The deal is, you guys would know if it was real labor or fake labor if you could do a vaginal assessment. But we don't teach EMTs vaginal assessments. We don't teach most paramedics vaginal assessments. We only relate that to high ROB paramedics and nurses. So if you're in a high-risk OB team, then you might do vaginal assessments. But most pre-hospital providers do not do vaginal assessments where you assess the cervical dilation and you assess the effacement of the cervix. And so your only gauge will be whether you think the labor is progressive or not. So think about that. Let me go to the attendance sheet. Since that person has not realized that I kicked them out, I'm going to think that they are not in lecture. Didn't return back from break at 9:20. Oh, I love note keeping. A running record makes me happy. Anyways, whether it's progressing or not, that's important. This coffee is so good right now. Saving my whole life. It tells you that the third stage can be up to 30 minutes. It's normally quicker than that, but it could be. So you got to watch for bleeding. You got to watch for if there's more than one baby. That's important. So I'll ask you again, how much bleeding is too much bleeding? More than 500 cc's, which is kind of something you're going to have to eyeball. But if the average 5x9 can hold X amount of cc's of blood, let's go Google that together. Okay, how much blood can a 5x9 hold? Let's see what we come up with. Basically, they came up with 4x4s versus 5x9s. They came up with 4x4s. This is a surgical study that's on the dermatology online journals from eScholarship. They came up with, based on 4x4s, a 2x2 can hold about 5 cc's of volume. So then a 4x4 can hold 10. So then a 5x9, we're going to say, can hold 20. And so if you are in, I think it could probably hold about 25. It could hold a capacity, 2x2 galls of 3, 4x4, an average of 10 cc's. So we're going to say that a 5x9 which is a little bit bigger than a 4x4, and it's thicker too. It's much more thick. The 4x4 is kind of one ply-ish. I'm going to say that a 5x9 can hold about 35 cc's of blood. So if you're in 5 of those bad boys, it would take a lot of those before you would realize that you were that far in. So if you're using 10 5x9s, that's a lot of bleeding. I'd be pretty concerned about the fact that I've met my 500 cc's. So I'm trying to just give you a method of more than just the number. The number helps you on the test, but it doesn't help you in practicality. So if you're, replacing 5x9s left and right, I'd be kind of concerned. Now, this is postpartum. We're not talking about the bleeding and the gushing that occurs with the delivery, because that is kind of rushing and it is a lot. It's a fountain of unending fluid. So that's kind of crazy and fun. Well, not all the way fun, but still fun. After the delivery of the baby, though, and in the placental delivery component, measuring that bleeding would be very important. And if the patient continues to bleed profusely, then that's postpartum hemorrhage. So we need to talk about what to do about postpartum hemorrhage, because there are some very physiologically cool things you can do to make mom stimulate the cessation of postpartum hemorrhage. The first of being is you can put the baby on mama's chest and start suckling. If the baby starts suckling, it releases oxytocin, and oxytocin causes vasoconstriction. You can massage the fundus by finding the top of the uterus and massaging it in a kneading fashion. They say it's like kneading dough. So kind of pressing and turning to the, clockwise motion. Press and turn, press and turn, press and turn. Kind of a circular pressing and turning motion. That also releases oxytocin, which will cause vasoconstriction, and vasoconstriction will reduce blood flow. So that's a physiologically cool thing you can do to help mom kind of clear up that bleeding process post-delivery and not end up going into a postpartum hemorrhage scenario. I will tell you that postpartum hemorrhage is not super common, and it is very dangerous. It is very difficult to stop. It can for sure kill a normally healthy, no other chronic medical history person in a matter of minutes. It's very devastating to see. So if you think you have profuse bleeding, be fast to intervene. Get oxygen on board, get blankets on board, get the appropriate position on board, start the fundal massage, get baby to start suckling if you can get baby to start suckling, okay? Another thing we didn't talk about that we need to talk about is cutting the cord, okay? Cutting the cord is something you should probably let a parent do if they're present. We shouldn't do it if someone else can do it. You want to make sure you leave enough room between baby and your first clamp, okay? Baby and your first clamp. There are cord cutting videos on YouTube, so if you want a visual, they're available. But the clamp that you put on the baby first, per the book, needs to be about 7 inches away. Let's go see what what number they actually give. That's postpartum hemorrhage care. Let's see what numbers they actually give. Umbilical cord around the neck. Your book is going to give some numbers. I want you to look at those numbers. I can't find them right here. They're easily available, but it's talking about every freaking thing else first. So I'll talk about it when we get to it, but you want to give yourself enough room that we can cut the cord and access the umbilical vein. So if you cut it too short to baby, then we're not going to be able to get good umbilical access on baby. So remember that the cord stays alive for a couple of days and we can still use it. So if this baby runs into trouble in the next 5 to 10 days, you don't want to have taken too much cord away, because we're going to have to cut the cord down past the stuff that's dead now and get to the good stuff. So don't cut the cord too close to baby. Clamp number 1 typically is about 7 inches away from baby. I'll give you numbers specifically. And then clamp number 2 would go about 3 inches from that. Oh, welcome back, Tatum Duke. Let me put you back on the attendance sheet here. Returned 9:55. Yes, I did. Tatum, you still with us? I saw you typing. Okay, good. I put you back on the attendance sheet, and you've only been out for the time that you were out. All right. So make sure you have enough room from baby to put your first clamp. Put your second clamp about 3 inches from that, and then of course you cut in between them. It's a gelatinous little thing. It doesn't cut very easily. You gotta like saw at it a little bit, which is disgusting. And you should let dad or mom or parent, grandmama, the construction worker that helped deliver it on the side of the road, whoever, let them cut it unless there's nobody else to cut it, and then you can cut it. There is another talking point that's really important here. We do not prematurely cut the cord. There is no rush to cut a cord unless the baby requires resuscitation. Typically speaking, the book is going to say that you shouldn't cut the cord unless the cord has stopped throbbing. Remember that there is an artery. There are two arteries and one vein in the umbilical cord, and it is pulsating. So once it stops pulsating, then you can cut the cord. You don't want to cut it prematurely. Typically speaking, around 10 minutes is what we would expect, as long as the baby doesn't require resuscitation.
You are now muted.
You fucking thing.
You are now unmuted.
Sorry, the computer is being stupid. So as long as the baby does not require resuscitation, then you should not cut the cord early. Cut it delayed. We say we prefer delayed cord cutting. Let it hang out a little bit. Let it stop throbbing, and then you can cut it. When the baby comes out, we are going to get an APGAR score. APGAR scores are going to be achieved when the baby comes out. And of course, they wouldn't have been intelligent enough to put that slide right next to having mentioned it. So I'll go into your screen share mode and I'll show you APGAR, which is really easy. APGAR goes 0 to 2, and there are 5 components, A, P, G, A, R. So you're going to get all 5 of those. And there are tons of resources for APGAR, so you can look it up on Google real fast, just like I'm doing right now. And you can get it that way. So here's APGAR. It judges the appearance, the pulse, the grimace, the activity, and respirations of the baby. Okay? When we say activity, we're talking about the fact that they are moving their extremities. Okay? When we say grimace, we're talking about crying, and we're talking about the angry face. Babies have an angry face. They look like little angry, pissed off old men. So if they're doing that very well, then they would get a 2. If they're not doing that at all and there's no crying, they would get a 0. So as you can see here, 2 times 5 is 10. The best you can be is 10. We get an APGAR at 1 minute of life. We get an APGAR at 10 minutes of life. And normally you'll see a 5-minute APGAR too, depending how busy you are. But 1 minute and 10 minutes we definitely get. A baby should not be an APGAR of 10 until 10 minutes. When I say should not be, I don't mean that they are not allowed to be. I mean that you can't consider it a bad thing if the baby's APGAR score isn't 10 until 10 minutes. It takes about 10 minutes for the SpO2 to actually be reliable. It takes about 10 minutes for you to see the baby in their most reliable assessment version. When you come out of the womb, you don't just instantly have normo hemodynamics. You are still perfusing a fetal perfusive manner. If you don't know this, the way blood circulates in the fetus is not the way blood circulates in you and I. The fetus bypasses the lungs because it would be a waste of time. It would be a waste of energy. So they bypass the lungs via the pulse, the PDA, okay, the pulsus ductus arteriosum. they bypass the lungs by perfusing around them to the rest of the fetus. When you come out, you need about 10 minutes for that PDA to have closed enough for perfusion to be really reliable. So what I'm saying to you is the 1 minute one is not going to be great. The 10-minute one should be great. That's how you judge it. The 1 minute one, okay, fine, it looks all right. The 10-minute one should be great. It is normal for a kid to come out acrocyanotic. They look blue in almost all places but the core. The core should be pink, but the rest of them should be blue. And it takes a little while for them to get angry and mad. So you just got to dry and stimulate them when they come out. You just want to take a blanket and kind of dry and stimulate their little chest and their little back. And you just rubby. And they'll start crying. They'll get angry. And you may have to suction their little mouth and nose. You may not have to suction their little mouth and nose. We'll determine that by whether they get angry quickly or not. All right, so let's talk about this APGAR again. Now that we kind of understand it a little bit better, baby comes out, we dry, we stimulate, maybe we suction the mouth and nose, always the mouth first, then the nose, because M comes before N on the alphabet. So we do that, and we've got an APGAR at the 1 minute mark. Appearance is whether they are all the way blue or acronotic. Okay, if they are all the way blue, it's a 0. If they're acrocyanotic, it's a 1. And if they're pink already, it's a 2 because pink is great. Pulse is judged by, is it fast? Is it less than 100? Or is it arguably 0 is not what we're looking for? Less than 60 is what should go here. In this box, it shouldn't say 0. It should say less than 60. Because less than 60, and we're going to start compressions. You're going to come to know that. So I don't agree with this number here. So if it's above 100, it gets a 2. If it's below 100 but above 60, it gets a 1. And if it was below 60, I would give that a 0 because you need to start compressions. For grimace, is it a strong cry? Is it a weak cry? Or is there no cry? If it's strong, it gets a 2. Weak cry gets a 1. No cry gets a 0. For activity, are they flopping or are they not flopping? Okay, are they moving their extremities well? Are they angry? Are they pissed off? Are they riding the bicycle, as I call it? They should be riding the bicycle. If you mess with them, they should start punching out their little arms and they should punch out their little feet. That's called riding the bicycle. If they're not doing that, then we start taking points away. So if they're doing it really well, they're moving a lot, we're going to give them a 2. If there's a little bit of extension, we're going to give them a 1. And if they're just laying there, which is super bad, we're going to give them a 0. Babies don't just lay there. They're a little crazy mess. They're constantly trying to move and mess with you. They're angry, so floppy is bad. Respirations, we're going to go with strong cry, and above 20 is good. Below 20, which is going to be called slow, is bad, and that'll get a 1. And then if they're not breathing, I do agree with apneic here because not breathing would get a 0, and that might indicate the need for Narcan, and it definitely indicates the need for positive pressure ventilation. Never, ever should you be focused on Narcan over ventilation. Ventilation will always come first, whether that's a 90-year-old patient or a 0-day-old patient. Ventilation would always come first. If a baby is apneic, start positive pressure ventilations on room air. Period. If a baby is less than 60 on heart rate, start compressions. Period. You got to remember that. Later on, when we learn neonatal resuscitation, we're going to discuss that you go in these 30-second cycles. And that is true. If the baby comes out not looking great, you're going to dry and stimulate them for 30 seconds. And then if they don't look great still, you'll give them blow-by oxygen for 30 seconds and see how that works. However, although that's true, at any time the baby is not breathing, you should be breathing for them. At any time the baby has a heart rate of less than 60, you should breathe for that baby and see if the heart rate immediately increases. If it doesn't, then you should start compressions for less than 60. Okay? Any questions about neonatal resuscitation and APGARs, which you should have questions about because that's a lot of material. And resuscitating neonates is not easy. It's a difficult thing. It normally requires 3 to 4 people. Breathing with a bag valve mask for a neonate is pretty difficult because their little airways don't like to let the air go into their lungs. They like the air to go into their belly. So you've got to get really good at putting some towel rolls underneath the shoulders, a little towel roll underneath the head, so that you kind of bring that ear, the end of their ear, up to the line of their sternum. So you're basically raising the head forward, not back. Not a head tilt chin lift. You do not do head tilt chin lifts on neonates or infants. You should push their head forward towards the ceiling as a unit, not a head tilt chin lift. Hey, babe. Let's take a 5-minute break. I gotta redo my coffee. So we'll come back at 10:10.
You are now muted.
That note. Last day. Sugar. Much better. Very nice.
You are now unmuted.
All right, back at it. Everyone put your hands up if you can hear me, please. Wave them in the air if you just don't care. Mila, because she's my party partner. 14 people out of 23. Let's keep going. Caroline, are you back? Matt Pierce, are you back? Matt Gaskins. It's not Matt Pierce. Matt Gaskins. I couldn't see that. Should. Okay, I know Megan and Patty are back. Party time, Mila. 20 out of 23. That's 1, 2, and I am the third. Okay. All right, let's go. I'm dying. Lower hands, lower hands, lower hands. Okay, so we talked about how to. Stop it, Patty. We talked about how to get the baby out. We talked about how to assess the baby when it comes out. We talked about drying and stimulating. We talked about resuscitation if it were necessary. We talked about suctioning. We said that not all babies require suctioning. And when we talk about suctioning babies, we are also talking about bulb syringe suctioning. We're not talking about using, typically speaking, we're not talking about using your automated suction device. That's too much suction for them. So you would be using neonatal bulb syringe, suction bulb. You'd be using one of these bad boys, okay? These are typically enough to suction in little neonates. And we would suction the mouth first before the nose because M comes before N on the alphabet. But let's talk about why we actually suction the nose last. Did you know that when you come out of the womb, you do not know how to breathe through your mouth? You only know how to breathe through your nose. That's why we call neonates nasal obligatory breathers. They don't know how to breathe through their mouth. And so research has been pretty amazing in this topic. In fact, the American Academy of Pediatrics released a position statement, and there were multiple studies that came about in the last 5 to 8 years that suggested the number one reason we were having as much respiratory distress in clinically admitted patients in the pediatric world was because we were failing to review them as nasal breathers. We weren't clearing their nose passages from the gunk, the snot. They tend to get a bunch of rhinorrhea, which is a runny nose. That gets thick and it'll eventually get crusty and it builds up on the nares. And so if that's the only way these young kids know how to breathe, then it makes sense that we were neglecting that nasopharyngeal care. And so then a lot more of these patients were getting admitted. A lot more of these patients were progressing into respiratory distress, not because of the viral infection component that started all of this, not because of the bacteria that started all of this, but simply because we were not addressing the passage that they are breathing in. So we have to remember to focus on suctioning. Okay? So do all babies need suctioning? No, we would only suction them if we think they need suctioning. If you see a bunch of gunk, then suction the gunk. You're going to suction the mouth first, then the nose, because if you stimulate the nose, first. They'll take a big breath, and then all of that crap stuck in the back of their mouth, they're going to breathe it in. So that's why we suction the mouth first and then the nose. Now, you got to remember how to use one of these things because some people get it backwards, okay? You got to press it and then put it in. Don't put it in the patient's nose and then press it. Obviously, that's bad. It sounds really easy to understand, but it ain't because I see people using bulb syringes incorrectly all the time. Here's why. You get ahead of yourself. You see the baby needs suctioning and you're too quick about it, and you don't take the time to squeeze the bulb before you put it in the nose, and you're being too fast. We always say there are no fast hands in the cockpit. There are no fast hands in the airway. You can move with a purpose, but you can't get fast enough that your purpose is not effective. So if you're moving so fast that you end up squeezing that bulb once you're in the patient's nose, you're causing more harm than you're ever causing good. So make sure you're aware of that. Squeeze the bulb, then put it in the nose. Fundal massaging, we talked about that. We discussed that newborns need to be fast heart rates and fast breathing. We want them breathing above 20. We want their heart rates above 100. A normal fetal heart tone, by the way, a normal fetal heart rate, by the way, is about 140 to 180. So obviously, we don't want them coming out with heart rates less than 100. When we do CPR on a neonate, let's say the neonate is not breathing. Let's say the neonate has a pulse that's 40 at the brachial artery. Because remember, we're going to check the brachial on these super young babies. We don't check carotids. We check the brachial. So let's say this baby comes out. You've dry and stimulated. You suctioned. You were trying to get this baby to breathe, but they're not. They're not breathing. And their heart rate's 40 at the brachial. Then you're going to start 3-to-1 CPR, and it literally is that fast. It's 1, 2, 3, breathe. 1, 2, 3, breathe. 1, 2, 3, breathe. It's very quick resuscitation. So you got to get it right. Most often, this is done by a specialized team that specializes in neonates. You can't typically do well in the neonate world if you're not familiar with the neonates. So if you are in the position where you're having to do this, you got to get it right, okay? So your compressor needs to have the circumferential thumb technique. So that's 2 thumbs in the center of the chest bone, hands wrapping around the back of the patient. That person is going to compress 1, 2, 3, breathe. 1, 2, 3, breathe. Once you get your rhythm, you want to start speeding that up. However, you gotta make sure the person at airway is getting good chest rise and fall with their breaths. Otherwise, this whole thing is useless because the number one cause of neonatal bradycardia, the number one cause of pediatric bradycardia is hypoventilation, not breathing enough. If you want to solve their problem, you need to breathe for them. So you got to get the breathing right. If you were looking at the adult world, we said that wasn't super important, and it's not. But in the neonatal world, in the infant world, it's extremely important. The number one cause of neonatal bradycardia is hypoventilation, low ventilation, or the absence of it, which would be apnea. So you got to get the breathing right. 1, 2, 3, breathe. 1, 2, 3, breathe. Meconium is that poop that we talked about when the baby ends up pooping inside of the amniotic sac. It comes out dark yellow, kind of brown. That needs to be suctioned, okay? You need to suction the mouth, then the nose. Suction the mouth, then the nose. We already talked about APGAR scores. There's the chart. So here, they're not giving a number for the respirations. I like to give it 20. Above 20 makes me happy. Below 20 makes me worried. So they're just saying They're rapid, they're slow, or they're absent. For heart rate, notice that the book is calling for more than 100 is 2, less than 100 is 1, and they are again using the 0. So since they're using it, I'll give it to you. I don't like it. It doesn't make sense if you're looking at neonatal resuscitation as put on by the Academy of Pediatrics. They do not assess absent pulses as being any different from a pulse of less than 60. However, if this is what the book is going with, then I want you to go with it because, maybe a test question gets put your way based on absent and not by 60. So go off of their numbers, okay? Greater than 102, lower than 101, absent 0. One minute and then the 10-minute mark, okay? We already talked about why. Breech delivery is if anything shows up before the head, you should run. The answer is put mama on oxygen. Try to not have mama push, which is going to be difficult, and run, because you're not going to be able to deliver that baby easily with a breech delivery. If the baby presents with a breech and you're worried about the cord, you can get to the cord. So the head is almost always face down and should be allowed to deliver spontaneously. We shouldn't be trying to get it out, right? Almost always. That's not true, but for your book, that's what we'll go with. If you were worried about breech delivery, you should run because it's not going to go very well. Okay? This next slide says something interesting, and I want to make a point here. It says make a V with your glove fingers and position them in the vagina to keep the walls from compressing the fetus airway. If the baby comes face down, you do want to just give a gentle circular V kind of motion to the vaginal wall so that the head doesn't hang up, basically. That process should be, I see the scalp, I see the head, and shortly thereafter, the baby's head comes out, and then you have access to the neck. That's what you want. You don't really want the nose and mouth pinned up against the wall of the vagina. That's what it's telling you. This is a breech. This is bad. Put on oxygen, emergently transport. Put on oxygen, emergently transport. Prolapse cord is the only time you can put your hands in the vagina. If the cord is around the neck, almost always we can gently get the cord from around the baby's neck by trying to physically remove it from the baby's neck. If mom has pushed too far and the cord is now taut and it's actually pulling against the baby's neck, then you're not going to be able to get the cord around the head. That is the only time you can stick your fingers into the vagina and find the baby's mouth and nose, and then more importantly, find the baby's neck. And make sure that the cord is not circumferentially squeezing the neck. Now, in your head right now, I guarantee you that most of you have the idea that you don't want to be blocking the baby's airway. That's not the problem. This baby is not breathing. Babies are not breathing in the birthing canal, typically speaking. What you're trying to prevent is circumferential compression of the carotid arteries. This baby's blood flow to the brain is going to be stopped by that circumferential cord pressing around its neck. Nuchal means neck. Cord is obviously the umbilical cord. So if this is a nuchal cord situation, you need to create enough space between the patient's neck and cord to stop that circumferential compression of the carotid arteries. So the book will say, get your hands into the vagina, find the mouth and nose, work your way to the neck. It'll probably be down close to you. It seems far away when I'm talking about it, but it'll be down close to you in the birthing canal. And you want to create a V with your fingers. So think about your index finger and your ring finger. You want to open them up wide. Why? Because it's going to cause a pulling tension on the cord, and it'll give you just enough space that that cord cannot be compressing those carotids. At least that's what we're hoping for. As mom, and by the way, if this happened, emergently transport. As mom goes to push again, the baby's going to work their way down again. and the cord might become even more tight. You're always trying to see if you can get the cord over the baby's head. If you can, then work the cord over the baby's head and be done with it. If you can't, keep your hands in the vagina and keep that cord off of the baby's neck. So typically, if we assign someone to this job, you are to stay there until surgical cesarean removes the baby from the birthing canal. And then we're not concerned that the cord is strangling the baby's carotid blood flow. Any questions about that? All right. Spinal bifida, I'll let you read. It's where the spinal stuff comes on the outside of the baby. It's not very good. Make sure you're checking if this is just one baby or multiple babies. You always got to ask, are you delivering twins? Do you know if you have more than one baby in utero? Most often they will know, so you want to know that. Here's why you want to know that, folks. Medics are going to give something called Pitocin, which we've talked about. Pitocin causes vasoconstriction. Pitocin also will stop the birthing process. So if we get there and mom delivers baby number 1 and you tell us there's a lot of bleeding and we administer Pitocin, we potentially could be locking baby number 2 in utero, which isn't a huge deal, but it's a deal. We need to emergently get the baby out of there if we have done that. So don't be silly and get your medic to do something bad. Make sure that the baby's only baby 1 out of 1. There should not be more than one baby in there if we're given Pitocin. The same is true for you. Don't be having the baby suckle and don't be massaging the fundus if there's another baby, because you will stop the birthing process. You will turn that contraction and mobility from the birthing canal, you will turn it off. You don't want to do that because then we'll have to surgically remove baby number 2. So be careful with that. Don't let the medic give Pitocin until we know there's no more babies. And don't be doing fundal massaging and suckling until we know there's no more babies. Vernix is the little yellow stuff on the baby. Look at that weird yellow crap on the baby. That's called Vernix. It's so cute. It basically just keeps them from drying out and it makes them smooth and jelly-like so that they don't, get epithelial lacerations and bruising and tearing. Newborn babies have survived at very young week marks and very low weights, but that's not normal, folks. Basically, if you're in doubt, provide resuscitation. If the baby's not breathing, has no pulse, and they're way below the 28-week mark, it's likely that you will not need to initiate resuscitation. When in doubt, resuscitate. If that baby shows any attempt at living, you should resuscitate. Why? Because we're getting really good at getting these babies to survive past the gestational expected presenting point. So if they're 24 weeks, we're getting pretty good at letting them develop in the hospital versus in utero. That wasn't the case 10, 15, 20 years ago. So if the baby shows any attempts to breathe, if the baby shows any heart rate, then we should probably resuscitate. Past 41 weeks is bad. That's bad. We can't be in the oven too long. 42 weeks is the bad spot, okay, if you're looking at the test question. Scott's dying. All right, question number 1. A begins with cervical dilation and it ends with crowning. We hope that the first part presenting is the baby's head. So then A is correct. 23-year-old woman, 24 weeks pregnant, first baby, edema in hands and headache, visual disturbances, high blood pressure. What are they experiencing? Bravo. Preeclampsia. Whoops. You're transporting 8 months pregnant to prevent supine hypertension syndrome, then you should what? Obviously have them on their left side. Immediately after delivery of the head, you should what? Nope. Nope. Oh, we got all kinds of answers. D is correct. Check the umbilical cord. Remember, I said that babies do not immediately breathe in the birthing canal. They tend to breathe once they're stimulated to breathe, and not all babies require suctioning. So, if there's no indication from the question that the baby requires suctioning, then A and B can't be correct. We don't assess breathing effort and skin color in a baby's head that's presented because it's likely they're not breathing yet. They don't breathe when they present in the birthing canal. They could, but it isn't likely. So the answer wants you to realize that when that head comes out, your focus is not on baby yet, it's on the cord. Keep the cord off the neck. Will it likely be on the neck? No. Will that process progress quickly and now we'll have an angry, crying, breathing baby? Yes. But you got to focus on those things. Not all babies need suctioning. We don't check breathing and circulation until the baby gets out of the birthing canal. Upon delivery of the head, you note the umbilical cord is wrapped around the neck. What's step number 1? I'm dying. Yeah, you want to make an attempt to slide the cord over the head, okay? You do want to make an attempt to get the cord out and away from the baby's head. If we were in a place where we were stuck with this cord, we could do C. If we thought the cord was not around the baby's head, we could do C. A is a last effort, an emergent effort. You do not want to stop the flow to baby before they are breathing on their own and out of the womb. So A is not favorable. It is an emergent thing to do. It's not typically done in the pre-hospital setting. So B would be our best hope. C would be what we would do if we can't get the cord away from the baby's head. So then you would be putting your fingers in the vagina, creating a V so that the cord is away from the neck as much as possible, and you stay there. And then the rest of the cord that is visible, we should keep moist, and we should keep it warm. Okay? Does everybody understand that? So B, get it away from the baby's head. The need for and extent of newborn resuscitation is based on what? D is correct. Now, yes, APGAR is the components, of D. However, the 1 minute APGAR is not in and of itself a reason to resuscitate. We said that the baby's not going to look normal until 10 minutes. Now, if the baby wasn't breathing, yes, breathe for the baby. If the baby has a very low heart rate, less than 60, yes, start resuscitation, full resuscitation. But that's all based on respiratory rate, heart rate, and color, as well as tone, grimace. All right, let's do an APGAR. Very good. Very good. Nobody. It's an 8. Let's talk about why. If you came up with B, I know why you came up with B, but the question led you to miss one of the pieces. Okay? If you if you were putting up your fingers and counting, I bet you gave resist attempts to straighten its legs a 1. It should have been given a 2. Because high level of tone is a good thing. So the two ways we assess tone is we try to straighten out the baby's legs or we watch the baby ride the bike. If the baby's riding the bike, then it's automatically a 2. If the baby's not riding the bike, then try to straighten the baby's legs and see if the baby will resist you. If the baby does resist you, if they fight you, then that's a 2. And that's why it's not B, it's C. Let's go at their explanation. So they gave the heart rate a 1 because it was 90. They gave the acrocyanosis a 1 because fully pink is the best. They gave rapid respirations a 2, so then now we have 4. A strong cry is a 2, and if you're resisting the attempts to straighten the legs, that's a 2, not a 1. And there you go. Practice that a little bit. It's easy. It's not hard. I would say APGAR is probably easier than GCS. Easy question. No. Bad answer. We don't start compressions until 60. So D is not correct. The number one reason for neonatal bradycardia, which leads to arrest, is hypoventilation. So C is the answer. We don't start CPR for heart rates less than 100. We start CPR for heart rates less than 60. While assisting a woman in labor, you visualize the vagina and you see an arm coming out of it. First of all, that's scary. Don't try to put it back in. She tells you she feels the urge to push. What should you tell her? If you're picking B, I'm going to have to punch you in the face. So, Jonathan, you get a free punch. Kate Stribling says, I'm going to give 2 answers. We would never encourage them to keep pushing. Never. Because if it's stuck now, imagine how much more it's going to be stuck if you keep pushing. That's stupid. So B and D are stupid. A is a good answer because we need to keep it moist and we need to keep it warm. C is only for nuchal cord. So then I have to agree with Clayton and go with A. We should keep the arm moist and we should keep it sterile if at all possible. And that's been true for every single thing that's supposed to be on the inside that gets stuck on the outside. That's the same treatment we've been using for all of the emergencies that is true for. If something that should be on the inside is sticking out on the outside, we should probably try to keep it sterile. We should probably try to keep it warm. We should probably try to keep it moist. And it should not be allowed to suck air into the body. That is the truth for all things sticking out. The other answers are dumb. B, don't keep pushing. That's stupid. C is about nuchal cord. It has nothing to do with breech baby. And D, which by the way, we would never try to turn the baby. That's a paramedic skill. That's called shoulder dystocia intervention. We don't do that at the BLS level. And then D is also keep pushing. So that's why A was the answer. A newborn is considered term if it's born after the blank mark and before blank weeks. No. All of y'all are going with B? Except for, I think one person didn't. B is correct. I said 42 was the point in which we would take that baby. 37 and after is great. 32 and after is really great, but 37 is for sure great, and 42 is the stopping point. 44 is way too gone. 43 is way too gone. 37 is not enough. So that's why B is the answer. 37 weeks is great to 42 weeks before the 42nd week. The slide said 41 was the last week we should allow. A very big chapter, a lot of information, arguably one of my favorite components of what we do. I absolutely love being a high Rob medic. I love TOCA monitoring and contraction monitoring. I love fetal heart tone development and perfusion. This is such a super fun area of medicine, but it is a very in-depth and specific version of medicine. So you've got to familiarize yourself with fetal perfusion. It's different from an adult. The umbilical perfusion is different from how we think of the adult. You have arteries carrying blood away from the baby into the placenta, and blood is going from the placenta to the baby via the vein, which is just not how you think of it. Although, if you're using your brain correctly, it makes sense because vein returns blood to the heart of us. Why wouldn't a vein return blood to the heart of a fetus? So it can be confusing, but if you spend some time familiarizing yourself, it makes sense why that's the case. And if it doesn't, then go with the simple rule: arteries carry blood away and veins carry blood to, and that will save you. So the perfusion is a little different. The PDA, the ductus arteriosum, that is a special little thing that you probably don't know much about that you can read about in this chapter. So familiarize yourself with it. Read this chapter. If not once, I'd read it multiple times. It's a lot of information, and it's such a cool chapter. The other reason to really focus on this is it's high risk, low volume. Most of you are not going to see filled deliveries very much, if at all. Some people go their entire career and never see a filled delivery. And then there are people that'll get 3 and 4 and 5 of them in their career. So it really does depend on, what the EMS gods do to you. And I fully believe in that. Like, there are the EMS gods out there just playing with us. And some people get a lot of cardiac. Some people get a lot of airway. Some people get a lot of OB. Who will you be? I don't know. So if I were you, I would really familiarize myself with this because you very likely might be delivering a baby in the field. And although that would happen, even if you were not there, you're certainly going to feel more confident and you're certainly going to be able to provide more resources to that mama if you know what you're doing. Okie doke. It's 10:42. Let's come back at 10:50. We'll come back at 10:50.
You are now muted. You are now unmuted.
All right, everyone. If everyone's with me, can you put your hands up? Just kidding. Just kidding. Bailey, are you back? Bailey frickin' Powers. Tate seems to be maintaining better control of her computer. Very good. Oh, Bailey. Oh, Bailey. Let's kick Bailey from the class. See how fast she comes back. All right, my friends. Let's get into 35. 35, I think, is too big for... I may have to go into screen share. Stand by, my friends. Let me go to PowerPoint. My fingertip, my fingertip. Why is that song stuck in my head? Aha. Very good. I will screen share with you fine folks. Now, when I'm in PowerPoint, it won't let me see anyone's chat. So please don't let me miss something important. If you need to speak up, speak up. Pediatric emergencies. Let's get into it. There will be an emphasis in the book for pediatrics about abuse and neglect because obviously they're a vulnerable population and they need us to take care of them. We said before that my grandmother says we are once an adult but twice a child, and that's true. The very young and the very old need care. They need people to watch after them, and depending upon their age and depending upon their independence, they need more and more or less and less care. So in the case of the pediatric population, we're typically thinking of people less than the age of 8. Okay? Typically, you're thinking of anything less than the age of 8. Now, technically, the world of peds goes up to the age of 18. So we'll just put that out there. The book is going to address most of this towards younger children, but technically, this goes up to 18. And abuse and neglect are always something that's on our mind. I want to talk about the difference between abuse and neglect, because by the way, abuse is more understood. It's easier. Neglect is what will kind of get missed. So if you walk into a house that has 3 babies around the ages of 1, 2, and 3, and there's no groceries, there's no heating and air, there is a stove left on that's being unattended. These are neglect things that could result in injury or illness or death to children. And that is a reported obligation for EMS. We're not allowed to see vulnerable populations exposed to potential illness or injury or death potential and say nothing. We're not allowed to do that. So if we see a 2-year-old playing in the road, you can't just drive around. You got to stop. You got to call 911. In the EMS world, that is a reason for us to take a child into our custody. So, and of course, we would get DSS, the Department of Social Services, or Children's Services, depending where you work, they call it different things. So in Georgia, they call it DFACS, the Department of Vulnerable Adults and Family Services. So it just depends where you work, what they call that. But nonetheless, there is always going to be a state entity whose job it is primarily to protect the interest of vulnerable populations, like the very young, the very old, and the special needs or handicapped populations. So think about that. Think about the neglect, the components of neglect there. In the pediatric world, we're going to address specific emergencies that are most common to them. So we're going to talk about STABLE. STABLE is an acronym that will help us remember the most common emergencies that regard children. We'll get into that in a little bit. In the pediatric world, airway obstruction is common. Upper is your stridor, lower is your wheezing, and we think of them as mostly being when you were not educated to the EMT level, you probably thought of airway obstructions as things we put in our mouth or choking on food. And that is, of course, an option. But more common than that is parainfluenzal inflammation, bacterial inflammations of the upper airway, where we've contracted some, little virus or little bacteria that for whatever reason has acted upon our upper or lower airway. So you think about epiglottitis, you think about croup, you think about bronchitis, where that little virus and that bacteria is attacking the tissue lining the bronchioles. That would be lower airway. So we're going to talk about epiglottitis and croup and bronchitis again, even though we've already talked about it. Make sure you understand the differences for those. If a pediatric patient goes into a respiratory arrest, it's likely that they'll go into cardiac arrest because the number one cause of pediatric bradycardia, which leads to cardiac arrest, is hypoventilation. They're not getting enough oxygen, they're not getting enough ventilation. They obviously can go into shock. We're going to talk about the fact that we call them cliff divers. The pediatric population tends to have healthy hearts and healthy lungs. When you're 50, you've had time to make bad choices, smoking, drinking, fried chicken, biscuits, when in fact you could have been making better choices, consistent exercise, a better diet, not smoking, not drinking, not being obese. But the children population tend to not have those existing conditions, and so their hearts and their lungs are healthy. Because of that, they mount fierce compensations, and they will mount that compensation up to the point of cardiac arrest, which is not like the adult population. In the adult population, you got to see the stages set apart from one another. You have compensation, that looks a certain way. You have decompensation, that looked a certain way. And then you had irreversible shock, which was probably in the peri-arrest or cardiac arrest phase. In the pediatric population, however, we are not as able to see those phases of shock play out. You're probably going to only see compensate, arrest. You need to have that dynamic, that change in assessment dynamic on the forefront of your thinking as you approach a pediatric emergency. You can't get a false sense of security in the fact that really high heart rates and really high breathing rates and the earlier signs of shock, you've got time. Well, maybe you don't, because for all you know, this healthy heart and this healthy set of lungs has been doing this compensation for hours. So it's misleading. Your index of suspicion with children has to be higher. Seizures. Let's break seizures down into two categories for pediatric patients. Okay? Let's look at them from the febrile seizure standpoint, which is seizures caused by fever, or more importantly, caused by a rapid change into a fever. So they went from normothermic to hyperthermic very quickly. That causes seizures. In your note taking, you need to know that febrile seizures typically occur before the age of 6. We grow out of it after the age of 6. So if a seizure occurred in an 8-year-old, I would be way more suspicious that that seizure was a neurologically induced seizure, or even worse, trauma, hypoxia, hypovolemia, sepsis, brain injury. Those would be the causes I'd have on my mind for an 8-year-old patient seizing. But if a 2-year-old patient seizes acutely with no previous history, the immediate thing on my brain is this a febrile seizure? What is the temperature of the patient? We'll get into more information about that. We're going to talk about SIDS and the limited amount of information you'll need for SIDS. Trauma in peds, I want to give you the same talk. You don't know where in compensation they are, so you have to be suspicious that any amount of compensation is aggressive compensation, and so they might be internally bleeding. Your index of suspicion needs to go higher. We're going to learn that your assessment component, specifically speaking, your general impression, approaches the patient differently than your general impression in the adult. The general impression of the pediatric patient is from the PAT assessment, the pediatric assessment triangle. We're going to talk about that in a minute. Versus when you walk across the room and form a general impression with an adult, you're looking at it from, what do I see? Are they awake? Are they moving? Do they look at me? That kind of perspective. In the pediatric world, their development is different. So then you have to look at their general impression a little differently. And we do that from the pediatric assessment triangle. We're going to talk about that. Always get on a child's level. Don't talk above them. They're scared of us. So don't bring 72 of us in the room unless we have to. And if they're of an age where they can answer our questions, they should be answering our questions. Don't let an entire assessment occur around a child when that child could have participated in the assessment. So there's that. Here's your growth and development chapter coming back to you a little bit. You do need to go back through this and remind yourself, because you are going to see some test questions that try to make sure you're aware of the development of mental status. When should an infant be meeting certain expectations? When should a child? When should a toddler? When should an adolescent? You're going to need to make sure you know what appropriate mental status looks like for each stage of development in the infant population, in the pediatric population. I want to also remind you that one of your assessment features that is most important is capillary refill. Capillary refill is most accurate in the pediatric population. So make sure you are applying capillary refill to these patients. It should be less than 2 seconds. And if you need a reminder, if you take your thumb and you press it into the palm of your hand, it'll turn white. If you let it go, it should immediately fill back in with blood. You can do the same thing on your nails, your fingernail beds. It should turn from white to red immediately. Because the capillaries are refilling that space with blood, that should be less than 2 seconds. It's most reliable in the pediatric population. As we age, we aren't positioning those capillaries as aggressively as the younger children do because we're getting old. When we get into the super young, like in a crib, you need to be thinking about APGAR, okay? If I'm talking about a 3-month-old, APGAR is still a good thing to use because they should be kicking, they should be crying, they should be angry, they should be pink. Their APGAR for a 3-month-old, an APGAR for a 2-month-old, a 1-month-old should be the best APGAR. It should be a 10 because after the 10-minute mark, a child's life reaches 10 minutes. It should be an APGAR of 10 from that moment forward. If it's not, then you are already in trouble. Make sure you're coming at the younger children, the ones that can't talk, that can't express themselves. Make sure you're coming at them from a perspective of what is their tone? Do they have kicking out? Do they keep me from straightening their legs and arms? Do they have muscle tone? Are they moving? Are they awake? Are they crying? Those things are reassuring signs in the youngest of populations. If they're 3, 4, 5 months old, do they grip my finger? Okay. Do they hate when I'm clicking the bottom of their feet? They should. They should hate that. Okay. So slapping the bottom of their feet should result in anger. They should probably cry. They don't like it. This is just going through the additional developments of the older stages. Those children tend to be able to interact with our assessment a little bit better. You are going to see a good bit of questions about the differences between the adult airway and the pediatric airway. I want you to just take a look. This picture on 35-9 is misleading because the back head, the occiput of a pediatric patient accounts for a lot more body surface area than the adult. If you were to put a 1-month-old on its back on a hard floor, the chin would move towards the chest. Not the case with an adult, not the case with older children, but just laying them supine does not actually open their airway, it actually closes their airway. So you've got to always remember, if you want an airway of a child, a young child, an infant, a neonate, if you want that airway open, you need towels underneath the shoulders, and you probably need some towels underneath the head so that you can bring that ear, the bottom of their ear, to the top of their sternum. Okay? Ear to sternal notch is what we're looking for. So if you're looking at this picture right now, I don't know if you can see my pointer. I hope that you can. But on my pointer here, the ear is lined up with the shoulders. Bad. If I wanted the best out of this airway, I'd raise the patient's head forward in this direction, and I would try to get the earlobe in line with the sternum. So the ear would need to be in line here, which is achieved if you take towels underneath the head and raise the entire head forward. Not by a great margin, but just an inch or two. The takeaway is head tilt chin lifts do not work in younger children. You have to shoot for the earlobe in line with sternal notch approach. The book is going to be clear that the pediatric airway is smaller in diameter and shorter. That makes sense, okay? It's going to tell you that the glottic opening is much more anterior, which we know to be if you were a medic, you would know that aggressively because they're very difficult to intubate for that very reason. The glottic opening is more anterior. It sits more on top of the space than you're used to. So it's harder to see if you're looking down the throat. Okay. The epiglottis space, all of that space is proportionately longer as the child develops. You're going to see a lot of talk about a U-shaped epiglottis. I want you to pay attention to that. Anatomy of the airway differs from adults in the fact that their tongue is larger, they have less mouth space, they have long, floppy U-shaped epiglottises instead of your standard kind of vaginal-looking epiglottis that makes a V, and they narrow and funnel in the upper airway. That's going to be a test question. They narrow and funnel in the upper airway. That's why a little bit of nasopharyngeal or oropharyngeal swelling causes a much more drastic response in children. That's why an adult can tolerate epiglottitis much better than a pediatric patient. Our airways don't funnel as we go up. They tend to be broad and symmetrical from the nasopharynx to the oropharynx, from the oropharynx to the glottic opening. That's not the case with pediatric airways. So spend some time taking a look at that. Their breathing rates are higher at baseline. Their heart rates are higher at baseline. Blood pressure, not so much. Blood pressure tends to be lower than you're used to. So you'll need to realize that the blood pressure is much lower than you're used to. Here's a sign that gives you kind of the heart rates, since the other slides gave you breathing rate. I'll help you with the blood pressure. There's a little go-to cheat. It should be 70 plus 2 times the patient's age. Okay, so if I'm a 4-year-old, then the lowest systolic I would accept is 78. And we're talking about the lowest number. Excuse me. Blood pressure is not the best predictor of pediatric perfusion. Capillary refill is. So if a 4-year-old did have a 78 systolic, but my capillary refill was 4 seconds, I would err on the side of the capillary refill. Even though that systolic is right there at the baseline, the capillary refill is too far. It's too long. So then that child, in my opinion, is showing signs of shock. You wouldn't give the blood pressure as much credit as you would be giving that capillary refill, as you would be giving their mental status. So if I have an 8-year-old, 8 times 2 is 16, 70 plus 16, so you're looking at 86, so I'd probably go with 90 systolic would be the least I'd accept from them, which is the adult. And that is why the American Heart Association continues to say at 8 years old, we're typically in the height and development expected of the adult population at about 8 years old, which is something you probably didn't use or relate to very much until you got into this class. The pediatric brain requires a lot more nutrients, cerebral flow, oxygen, and sugar. So their volume status is very important. If their volume status is low, then their brain perfusion is going to be low. And they're going to use more oxygen and more glucose to compensate for that. So they run out of nutrients pretty quickly. Their bones are green stick bones. They're not as developed as ours, so they tend to bend more, which is a good thing, but they can have fractures in their bones that don't look grossly deformed, that don't look grossly swollen because of that bending versus breaking phenomenon that tends to happen in children. We call them green sticks. And if you've ever bent one of those limbs off a tree that has green on the inside of it, it's highly saturated with moisture, and so it doesn't break and snap, it bends, and the bones of children are kind of looked at from that perspective. So you have to have a higher index of suspicion with children and broken bones because that bone will bend. It doesn't necessarily snap. The children don't protect their integumentary system very well. They have a harder time maintaining their hemodynamics in regards to thermomanagement. We know that the hypothalamus regulates the internal temperature of our bodies. That hypothalamus is definitely working well in children, but it isn't as developed. It isn't as educated. It isn't as informed. So they don't develop that good hypothalamic response system until they're getting towards the 8-year-old line. If you're talking about neonates, they don't protect their temperature at all. So we have to protect them. The very young and the very old start losing that ability to protect their temperature. So keeping them warm is a big deal for us. Okay? The younger you go, the very old that you go, the more likely we need to be supporting that patient's thermomanagement. Their hypothalamus is not as efficient, not as informed, not as capable as yours and mine. So we talked about this. We're doing a general impression from the perspective of the pediatric assessment triangle. This isn't grossly new. This is just you articulating your general impression from the perspective of what you expect to see visually in young children. Their appearance, they should be moving, they should be fighting, they should be pink when you look at them. They should be pink. They should be crying and angry and feisty. That would be appearance. Work of breathing. We're going to look at them from the toe to the head. I want you to pay a little bit of attention to that. You want to look at them from foot to head. Why? So that you can better see the work of breathing. If you're looking from belly to chest, since the belly is not supposed to be rising and the chest is, it's easier to assess the belly from the chest to assess the chest from the baseline of the belly. You can easily see that work of breathing. So we like to look up children. With adults, we kind of just go head to toe. With children, we go foot to head. Work of breathing should be assessed by you getting to the foot of the patient and looking up that patient's chest and seeing that the belly is at baseline, it should be low, and the chest should be rising high. If work of breathing is increased, you would note that. Circulation to the skin, again, this is performed by just visual. We're not touching them, so it should be pink. It should be pink and vibrant. It should not be cyanotic. It should not be acrocyanotic. So the pediatric assessment triangle, if it was all great, would be a feisty, moving, awake kid who has no increase in work of breathing and is pink. Can you stop the cat from doing that? Like, touch it. Touch the cat. Just like give it a little naughty nod. The cat thinks Scott's going to open the food, so it's going nuts. This can be performed quickly, and it does not require you to touch the patient. I do want to add to this particular part here. The tickles mnemonic is really good. Pediatric population providers tend to really like tickles, but we tend to refer to them as disability patients. I've talked to you before that disability is mental status. I should be awake. I should be responsive. I should be a good AVPU. I should be a good consciousness. I should be a good orientation. So disability, appearance, level of consciousness, AVPU, tickles, they're all the same. Patients should be mentating. Tickles asks the provider if the patient is mentating. Disability asks the provider if the patient is mentating. So if I assess disability, I might find it to be lethargic. I might find it to be obtunded, which is completely unconscious, unresponsive. I might find it to be appropriate. If disability is appropriate, then it would say the patient is awake, alert, responsive to my expectation for that particular growth and development. The additional efforts given towards looking at mentation in children is because they don't have the development always to answer questions. They don't have the responses that are mature like you would expect from an adult. When an adult sees someone walk in the room, they naturally know to give that attention. Do children? It depends. If they're playing, no, they're not going to give it any attention. They'll probably miss it. They're very absent-minded, right? So if that's all true, if mentation is so different for them based on development, then that's why you have so much more resource given towards the assessment of such. So please commit tickles to your memory. Tone, moving, muscles, they should be feisty. Interactiveness is always a good one. If they're interacting, if they're very young, they should be so much more inclined to interact with mom, dad, parent, grandmother, brother, sister than you. That would be a normal finding. Interactiveness is a very good finding. Consolability. If I'm holding them and they're screaming like hell and fighting, and I give them back to mom and it calms them down, that's great in the words of mentation. If you're looking at the brain's performance and its awareness, consolability is a great tool. They should know who is friend and who is foe. Once they get to that 2, 3, 4-year-old age, they've really got that down. Look or gaze. They should follow you. They're afraid of you, so then they should be watching you. They should be looking for mom and dad. If a child is staring off, that is a very bad sign for mental status in a child. Speech or cry gives you a lot of information. Is the cry without adventitious noises? Do I hear a stridor in that cry? Do I hear croup sounds in that cry? Is the cry clear and as expected? So paying attention to tickles is a pretty great tool that rounds off the disability assessment of the pediatric population. Obviously, we're doing X ABC, life threats, ABCs. X means to expose. You're exposing the patient because we don't find what we don't see. So we're exposing the patient looking for life threats and ABC problems. Obviously, bleeding will always be first. There's no reason to do good compressions and breathing on people who are bleeding because they're going to die anyways. So we've got to stop bleeding. Hopefully we can do them simultaneously. Assign someone to compressions, assign someone to breathing, and I'm going to take care of bleeding control. Hopefully that's the case. We recently had a pretty significant shooting. I was with Megan Golbus and Sarah Wiggins. We were on scene all together, the three of us. And we had this scenario where there were multiple penetrating life threats and the patient was not conscious, was not breathing, and did not have a pulse. So in that case, all three of us had immediate jobs to do. If we were going to attack the patient simultaneously with good intervention. If you were by yourself, you'd have to address those things in order. Expose, life threats, then A, then B, then C, provided the patient does have a pulse. If they didn't have a pulse, then of course you'd be CAB. If going through that with you verbally brings up questions, you need to be asking them because at this point in the class, you should be able to fluidly move between ABC and CAB. Unconscious, unresponsive gets CAB. Responsive and conscious gets A, B, C. You should be able to move back and forth. Even if the patient acutely changed, you were with a conscious patient who now becomes unconscious, you should revert back to the primary and immediately go C, A, B. Do I have a pulse? Now am I breathing? And then address the patient's ABCs as best you need. Exposure and disability are always on the pediatric assessment, so it's always going to be E, A, B, C, D, E. Bleeding, airway, breathing, circulation, mental status, expose the patient, and are they hot? Are they cold? At this point, I think it's a good place to bring up stable. When you are thinking about what kills children, the answer is stable. Now, stable is an actual class that advanced providers take, but as I began teaching EMT classes, it made me want to come up with something that you guys could readily use to attack the most common life threats that are positioned against kids. The truth is, pediatric emergencies are high risk and low frequency. You don't see a ton of true pediatric emergencies. And so if that's true, if you only see a few of these, then we need to be building as much mnemonic and cheat sheets and resources of assistance as possible so that you can address these populations well. You can't memorize all this crap. It's bullshit to believe that. So we come up with the Hentevi app. We come up with the Broslow tape. We come up with apps that help you know the normal breathing, normal pulse, normal blood pressure, normal mentation of kids based on their age, based on their weight, based on their height, based on their sex. That is fair. It's a good thing to use those resources. It is not a bad thing. It doesn't mean you didn't put in the work. It doesn't mean you didn't study hard enough. It means that this population doesn't land in our lap very often in an emergent way. And when it does, you should be available to the resources that will make you a good provider in that moment. Stable is one of those resources. Stable stands for sugar, temperature, airway, blood pressure, labs, which you guys can't really do on your end, but it's still something important for us, and environmental and emotional components. Are they in a cold place? Are they in a hot place? Are they in a place that doesn't have enough food? Are they in a place with no adult supervision? Stable kills kids. If you're going to keep kids safe, you come at them from the perspective of what is their sugar, what is their temperature, is their airway okay, what is their blood pressure, which, by the way, is known as capillary refill for you. Capillary refill is where the BP should be coming into play. We'll do labs for you, and then you need to consider that environmental emotional component. What if this kid is a SIDS kid and they're dead? And so now we need to provide some type of emotional support to the family. We need to be there for them. We need to call a chaplain. So that's how we address the pediatric population. Come from the perspective of stable. There are tons of resources available to manage children. Most of them are directed at the critical care environment. So take that for what it's worth. But there are a lot of apps out there that will help you know what the age should be, know what the rate of breathing should be, what the blood pressure should be, what the dose of this should be, the dose of that should be. There are tons of apps out there. Probably one of the most common go-to for that is Hentevi. If you were to go work at Berkeley County right now, for example, Berkeley County is one of, in my opinion, the best places for pediatric care because they have gone out and purchased the resources that they believe are necessary for their folks to take not just care, but good care of these patients. They have an app. The app is called Hentevi, and that's not an app you can go download. It's an app you have to purchase from a service perspective. And that app lets you choose an age, choose a weight, choose a height, choose a sex, whichever one's available to you. And then once you have done so, it immediately populates with all of the things you would need to take care of that child. What should the heart rate be? What should the breathing rate be? What should the blood pressure be? What is the dose of this? What's the dose of that? If you need airway control, what tools should you be using? It tells you everything. So never be afraid to use these resources, and never let anyone tell you that doing so means you didn't study enough, you didn't practice enough. That's not true. Every doctor that I know who treats children on the critical care perspective and the emergent perspective uses these types of resources. They do not try to risk this child's management off of memory. It's not fair, it's not smart, it's not intellectual. It's okay to use these tools. I want you to think about stable. I want you to really think about stable. And if you ever get a chance to take the class, take it. We've gone through all of those. Always remember that we have to secure children in the ambulance legally. You don't get a pass because you're an ambulance. Children that are transported in the back of the ambulance still have to be transported in a safe and legal manner. You go to your services and they're going to teach you what their policies and procedures are for the transport of children. Let's talk about spinal immobilization for kids. I think it's pretty clear that spinal immobilization for children can be good and bad. You got to use your brain. If you're trying to immobilize a 1-year-old, and in doing so, this child is now fighting you so badly that the neck and spine can't be kept still, then this is of no use to us. Stop doing that. If you can get something better on board, like patting the area of the patient with towels, then do that. If a C-collar will work, but they don't take anything else, then put on the C-collar. But you can't fight a patient into spinal immobilization, because by the time you get them immobilized, the entire point of it is gone. So that's stupid. You need to know that most ambulances have a built-in car seat in the captain's seat. Ambulance, captain's seat, needs. Let's see if it shows us. Ah, there we go. This is a type of securing device called the PD Mate. Love it, love it, love it. Okay, and let's see if it shows us the ambulance seat. Okay, so here is an ambulance seat. I thought. Here's an ambulance seat. That's what it looks like when you bring it down. If you didn't know that, in the ambulance that you've been riding on, for those of you who've done ride-alongs, for those of you who haven't, you're in trouble, but that's your problem to find out. If you've been doing ride-alongs, you know that this little seat here normally is folded up, looks like this, but you can break it down and it becomes this. So if you're talking about a child that can hold their own head up, then this is a good resource for you. If the child can't hold their own head up, then you're using something like this. There are tons and tons of different options out there for immobilization of children. On the helicopter, we use the Neomate and the PD Mate, which is this bad boy here. But there are tons of these, okay? So whatever your service uses, then that's what you'll use. Excuse me. Making sure I've attacked the points I want to attack. I'm letting you do the reading for yourself. I'm not going to read to you. We already told you about the 70 plus 2 times the patient's age. But capillary refill should always be your most important go-to. Kids do tend to nasal flare, so you got to look for that. Because their little nose is not so cartilaginously developed, they don't have as much hard cartilaginous development in their nose, then their nose will flare. So when they're having trouble breathing, their nose will kind of flap like a wing. So if you see nose flapping, also known as nasal flaring, that might be an increased work of breathing. So don't be afraid to oxygenate kids. We already know how to deal with foreign body airway obstruction, FBAO. We know that we, for the infant population, do 5 back slaps and 5 chest thrusts. For the older population, we would do the Heimlich maneuver, the abdominal thrusts, in whatever way we could, whether that's using a wall, using a chair, getting behind them physically because they're tall enough, whatever we needed to do. If they're responsive and choking, that would be our method. If they're unresponsive and choking, then we know to go to CPR. Asthma in children obviously presents with wheezing. Yes, you can use your albuterol for children. They tolerate albuterol better than adults do. So typically we'd see children on albuterol treatments that are 30 milligrams. So yes, the BLS provider can use albuterol for children if it were indicated and your guidelines allowed you to do so. I want to remind you that croup is seal bark like cough, noted here. That's how you know that that's a test question. Seal bark cough. Epiglottis is drooling, drooling, drooling. Seal bark like cough. Drooling, drooling, drooling. If you see those trigger words, it should answer how to correct it, how to choose it. Bronchiolitis, commonly known as RSV, respiratory syncytial virus, means that they are running into a scenario where they're not breathing in a good pattern because of the inflammation in the lower airways. So if the patient's in distress, give them oxygen. There's nothing else you can do for RSV. In fact, most providers at all levels aren't going to do a ton for RSV unless the patient becomes so severe that they're acidotic. Pertussis is the whooping cough. If the patient has a cough, make sure you're protecting yourself with a mask, eye protection, and gloves. You know about airway adjuncts. You can do adjuncts on kids just like you do on adults. Remember that the breathing rate for pediatric patients is 1 every 3. If a pediatric patient was not breathing but had a pulse, it would be ventilate at 1 every 3. This is just cute ways to deliver oxygen. We already know that you have nasal cannulas, you have BVMs, you have non-rebreathers. Yes, you can measure carbon dioxide on kids just the same. We have nasal cannulas out there for them too that measure carbon dioxide. Remember your capillary refill time. So, so, so important. Anaphylaxis dose of epi is 0.15. Give them oxygen, give them epi. If a child is altered, we have AEIOU tips. AEIOU tips. It's a very good mnemonic to remember all the things that could make a patient altered. It applies not only to children, but it also applies to adults. So you could look at that. Alcohol is a big deal with kids. They get into stuff. Epilepsy, endocrine or electrolytes, insulin, opiates, kidney failure, which is uremia. They're not peeing. Trauma and temperature, infection, poisoning, and psychogenic. So, kind of the same stuff we were thinking in O and a little bit of E. And then S, of course, is your shock, your stroke, your seizure, your syncope, which is passing out, and brain hemorrhages. Now, remember that kids can have strokes. Kids can have heart attacks. Kids can be born with congenital heart defects, which cause the blood flow in their heart to not follow the normal passages. So you gotta get a history. You gotta get a good sample. You gotta get a good OPQRST. We already talked about febrile seizures. We know that occurs most likely below the age of 6. I am going to talk about the difference in how children who are experiencing neurological seizures tend to behave than adults. Okay, so an adult is commonly going to become tonic-clonic, flopping like a fish. Children do not tend to do that. They have what we call passive seizures or partial seizures, where they'll maybe click their lips, they'll smack their lips and tongue, like making noises like that, and they'll kind of bounce their eyes, and their lips will be kind of shaky, and they're zoned out. They're not responsive to you, they're not answering to you, but you need to know that children who are experiencing seizures do not give away as much of an indication that they're having a seizure. They will have a change in responsiveness. they will tend to gaze off in one direction or another, and they will start smacking their lips, smacking their tongue, and kind of clicking their eyes. You might see a little bit of shaking muscle features in their face and neck and chest, but they don't get as wild as an adult having a seizure. You need to remember that. So it takes a little more paying attention. I already told you about meningitis, presents those red, blotchy, bruising looking things. Chin to chest hurts. They won't let you extend them out. They don't like to flex. They don't like to extend, rather. They like to flex. They want to be up in the fetal position. They don't want you to stretch them out. They have that bruising, blotchy skin thing. And they've got fevers, probably, most commonly. There's your slides. Out of this, appendicitis is very common in children. So if we've got right quadrant lower abdominal pain, volume is a big, big problem in kids. The most common reason why they would be lethargic and not really giving us much attention, they would not have much tone. They would, if you're looking at tickles, they're not really interactive. They're not awake very well. You know, you're having to stimulate them. Their capillary refill is delayed. That's commonly because of dehydration. It's commonly because of hypovolemia. They run into diarrhea and run into vomiting for almost everything you can think of. If a kid gets anything wrong with them, they'll have diarrhea. If that's not replaced, if it's not addressed, if it's not stopped, then it will result in dehydration. When kids get to feeling ill, they also will not drink and eat. So they are quickly susceptible to a volume problem. This is something we shouldn't probably be doing routinely, but it's skin turgor. Turgor is when we pull the skin up into a tent and let it go. It should just go right back to its place. And if it doesn't, that's kind of another way to know there's dehydration. In super young children below the age of 6 months, we're looking at fontanelles. If you remember, fontanelles are the soft spots in the baby's head. So you're looking at a 1-month-old, 2-month-old, 3-month-old, 4-month-old. Those soft spots aren't joined. The cranial vault is not completely sealed. So there's these soft spots. If you look at that baby's head and there are divots in that head, that's another sign that there might be dehydration. Again, less than 6 years typically. It's a short seizure. It's very minimal, 15 minutes or less. And I have never seen one go 15 minutes. It's way less than that. It's very brief, and they don't tend to result in postictal state. Those kids don't return to you super confused. Now, here's why I think the book is stupid for even mentioning that. If we're talking about a 5-year-old, then that's very observant. It's easy to say a 5-year-old is not confused. But most febrile seizures occur in the very young populations. We're talking less than 3. And they don't mentate the way you and I do. They don't come back answering who is the president, what day is this, where are you at right now, who's mama, who's daddy, who's me, what's your first name, what's your last. They don't know some of that information. So it's difficult to assess whether they do or don't have a postictal state. So it kind of angers me that the book drives that home, and it actually uses it in test questions. You're going to see test questions that say febrile seizures don't tend to produce postictal state, which is a useless piece of information, I think, because what it does produce is lethargy. All of these kids come back out of these febrile seizures very tired, very feisty. They don't want to be messed with. They want to sleep. They want to immediately be left alone. Well, that in and of itself, if you're looking at the Tickles mnemonic, if you're looking at the PAT, the Pediatric Assessment Triangle, if you're looking at the disability talk of the book regarding this population, lethargy, obtunded, in and of itself is an altered mentation. So I don't like it. I think you should go with the fact that less than 6, look for a fever. If it's a fever, they probably have a febrile seizure. It's going to be very brief, very short seizures. It can be many. They can have a couple. They can have 3, 4, and 5 of them kind of back to back, which is bad, of course. but they don't tend to have a lasting effect from these seizures. Okay? Now, clearly, the seizure is just one little piece of it. What caused the seizure? What caused the fever? Are they really, really sick? So, of course, all febrile seizures should be transported, in my opinion, because what if they have a nasty infection brewing and we're just going to dismiss it as being a young seizure and we're missing the whole cause, the whole fever cause? So, yes, we need to get the temperature down. That'll stop the seizures. But what caused the fever? We should investigate that. With drowning emergencies, don't forget your CPAP. Now, I will say that most protocols for the BLS level won't allow you to use CPAP of less than 12, but you need to know that we use CPAP on neonates every day. It's not a BLS skill, it's an ALS skill, but it's still relevant. And so if you were ventilating a 1-year-old drowning, I would expect you to be using a PEEP valve on your BVM. If your guidelines allowed you to. Now, sometimes guidelines will specifically exempt children from BVM PEEP valves, which I think is a little silly, but that may be the case. And if it is, then don't follow me, follow your guideline. I'm not a physician. But if your doctor doesn't specifically forbid them, then look at them. PEEP valve for BVM is CPAP. There's no difference in this. All you did was slap a PEEP valve on the end of your BVM and you turned it up to 5, 10, 15, 20. Now for kids, I'd probably stay at 5. I'd probably stay around 7. But if they've got fluid in those lungs, those alveoli are collapsed. Simply ventilating them is not going to work. Mark my words, it won't be enough. So then you need to use a PEEP valve if you have one available to you. I want to bring you back to this video so that you have a good visual on what it looks like to breathe without PEEP versus with PEEP. So here is a set of lungs that have been intubated, and on the end of it we have nothing yet. So we're going to look at how they rise and fall without PEEP first, and then with PEEP.
And you did a great job doing so. Okay, that's just about. You like that?
So this is without PEEP. Up.
Yeah. I'm gonna bag this up. It won't explode.
Sounds like a challenge.
He's bagging,
This is called
bagging,
recruitment.
bagging.
See what we're doing here? We're starting to recruit all these alveoli.
And now watch what happens when he stops bagging.
And I've got to really bag hard to keep these lungs inflated. Okay, and then it goes down.
All the way out. All of that is gone.
Okay, so
All
what
of
we
that
wanna
good
do is we
recruitment of
wanna
the
maintain
alveoli is
the-
gone.
The reason we use PEEP.
Now watch him when he puts the PEEP valve on. He was having to ventilate like one breath every 2 to 3 seconds to keep those lungs inflated. But here's a BVM with a PEEP valve on it.
This in with 5, and then I'll show you with 10.
Look at that. Look at that. Look how many pockets of air are showing up on those lungs. And then look how slow the exhale. It still didn't deflate all the way. It's just remaining inflated. So, I hope that gives you a visual to the fact that we physiologically, as a norm, we are breathing with PEEP. When you get exposed to drowning, when you get exposed to fluid in your lungs, that PEEP goes away. And the alveoli have nothing to hold them open. If you're not using a PEEP valve on your BVM, there's nothing to hold those alveoli open. So you're moving air, sure. Air's going in, air's going out. But nothing is getting to the alveoli. No, we do not tend to use albuterol for RSV unless there is a constrictive response. That would be more of an ALS thing. However, if wheezing is present, wheezing is present. That's why we don't use the diagnosis as the indication. We use the presence of an assessment finding as the indication. Wheezing is or isn't. If it is, then we would use it. Trauma is still the number one killer of kids. So our best way to keep kids alive is to prevent the emergency. Their heads are much bigger. Got to be thinking about that. Remember that when we break long bones, we bleed a lot. You can't see it, but it's happening. Femurs, about 1 liter apiece. Pelvis, 2 to 3 liters of volume. You got to be thinking about internal bleeding when we break significant bones. All right. I think that it's wrong of them to mention jumpstart triage with you not having learned start triage, but they do. So you'll have to look at it. The difference between triage of children and the triage of adults is that if we find an adult that's not breathing after we open the airway, we just pronounce them dead. In the pediatric population, if we find a child in a mass casualty incident not breathing, we would open the airway and give 5 rescue breaths. If that were to stimulate the child to breathe, then we would categorize them as red and not deceased. Green means A-OK, walkie-talkie. Yellow, sick but can't walk. Red, I'm dying, you better do some stuff to save me. Black, dead. This categorization has been changed from colors to priority. Priority 1, red. Priority 2, yellow. Priority 3, green. And priority 4, black. And that makes sense because dead people are not a priority in a mass casualty incident. There is your jumpstart triage mnemonic. I want you to look at it from the perspective of RPM. Respirations, pulse, mentation. Respiration, pulse, mentation. You do triage by looking at RPM. Vroom, vroom, RPM. Respiratory, pulse, mentation. Triage, I'm reminding you, is something we do when we have an overwhelming number of patients that doesn't allow us to treat everybody. Yes, that happens. For some of you more left-leaning liberal people, you're going to be pretty upset about that. Well, you're just going to have to be angry. There is a point in which there are more people to care for than there are resources to care for them. And in that case, we must triage those people based on data and clinical findings to choose who does get care and who does not. Wrap your brain around that, because that's a real life scenario. Whether you like it or not, that stuff's real. And there are cases in which we have to decide who can we most likely save. In the world of mass casualty, we're looking at the greatest good for the greatest amount of people. So we might have to acknowledge that nobody would be getting CPR. No one would be getting resuscitation. We would be trying to save the people most salvageable. Wrap your head around that. The child abuse mnemonic, you might see a quiz question or two about. It basically just tries to cue you in. We've already talked about this population being susceptible. And so some things that are definitely eye-raising or they get my attention with children and abuse is the child acting consistent with the injury per their development, okay? If a child has a broken arm and they're not crying and upset about that, you gotta wonder why not. Sometimes parents coach children before they call 911. Did you know that? They might have been coaching that child about how to act for that broken arm. If you act like that's killing you, when they get here, they'll take you away from me. That's the horrible stuff that happens before we get there. So, is the child acting like you would expect with that injury for that particular age? The history that the parents are giving us is inconsistent with the injury. Oh, they were just running across the grass and they fell down. No child is running across the grass, falls down, and is now unconscious on the ground. That could happen, but it is extremely rare, and I guarantee you, statistically speaking, it's abuse. Children are not just randomly unconscious in the absence of a medical emergency. If you can't find a medical emergency with that child, it's abuse all day until proven otherwise. Is the history that they're giving you consistent with the injury? The parents can be very distant from us when we get on scene. That's an eye raiser, an eyebrow raiser. If the injury was yesterday and you know the injury is significant, that is in and of itself a crime. It is illegal to delay anyone access to medical and trauma care. That is against the law. Delaying appropriate intervention is against the law. A is for affects, just kind of looking at their behavior. That one's not as reliable in my opinion. You can't really judge how someone is supposed to cope. We're not psychologists. B, bruising in different stages of healing. That's a big one. In places that bruising shouldn't be occurring, like the inner thigh or the inner forearms. If you go to fall down, the body responds spontaneously in a certain way. You put out your arms and you prepare for impact. If you have bruises in places they don't normally contact impact, I gotta wonder if that bruise was put there by a person. If you've got bruising in various stages of healing, that's not normal either, depending where those bruises are. Now, if you're a 6-year-old child, a 7-year-old child, 8, 9, 10, 11, 12, they're playing hard. So is that in and of itself good enough? No, but it should get your attention. You should be thinking, you should be looking. Unusual injuries, like dipping, for example. You may not have ever heard of this, but sometimes people will punish their children by drawing a really hot bath of water and then dipping their child in that water. So if there is a clean, beautiful line of burn, that is not normal. If you normally contact a hot solution, you're going to yank away from it. There will be splashing. If you don't see splashing wounds, that should concern the crap out of you. And then suspicious stuff and environmental cues, okay? Dun, 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 dun. Shaken baby syndrome, you need to look at it. You need to read it. It's very common if a child is unconscious and we can't find a medical reason. It will be investigated by law enforcement. We will look at it from the point of something we call non-accidental trauma. NAT. It's NAT until proven otherwise. There's nothing you can do about SIDS, and I do want to remind you. Sorry, guys. Teaching at home is very difficult here. SIDS babies, when they're dead, I just want to remind you, are just as dead as a human, adult human that's dead. There's no good difference in that. So why people try to work obviously dead babies, I don't know. But there is more of an urge to work a newborn baby that's dead in their crib than there is an adult that you find dead. If that person, that baby, is extremely cold to touch, is stiff from rigor mortis, don't try to resuscitate that baby. It isn't going to work, and it's going to cause mental trauma to you and to the parents. Now, if there's any doubt, work it. If there's any obvious sign of attempting to survive, work it. Don't assume that it's SIDS, but Alti, if you get a call to a 1-month-old who was feeding and suddenly they turned blue and looked like they were choking and quit breathing, and you go to a not breathing unconscious baby, you fly there, you're busting down traffic to get there, and when you get there, they all standing in the yard with a happy, healthy baby Don't start high-fiving. That's not okay. If that child had a period where they changed in consciousness, changed in color, and that period was while they were feeding, that is a really big indicator of congenital heart defect. It's a really big indicator of perfusion problems. It's called an ALTI, apparent life-threatening event. An ALTI is a brief episode where everyone freaks out and thinks the baby's dead, and suddenly they're not. We should not get a refusal on an ALTI. We should not all high-five each other and say, oh, thank God, there's nothing wrong. Pay attention. Don't just walk away from a scenario like that. ALTIs tend to be precursors to medical emergencies. That's probably a little bitty sign of a very big problem. So you got to be careful with that. I'll let you read more on that. Let us review, good children. Let us review. Bring up this. I'm going to put this over here. Now I can see. I'm going to bring this over here. No. I've heard 2 to 3 liters of blood and 500 fractures. Which is it? Jonathan, the answer is, I know you like very objective rules, but it depends on what's broken. So if it's a femur, your book says up to 1 liter per femur. That depends on growth and development, of course. If it's a pelvis, the literature will tend to suggest 2 to 3 liters of blood volume in a pelvis. So how much can you lose? Well, there are a lot of factors. So could you lose is an easier thing to answer. If it's arterial versus venous, if it's closed versus open, if it's adult versus a child, all of those things factor in, Jonathan. So get out of the mindset of chemistry, biology, lab test taking, because it will not work for you in medicine. There are a lot of really good physicians that make really great grades on tests, and then they suck at taking care of people. So get out of that world where you're looking for one answer that will be right every single time, because it won't. That's not life. That's not biology. That's why we call it the practice of medicine. All right. I'm done beating Jonathan up. I'm sorry, Jonathan. It's not you. It's not your fault. It would be great if we had one that applied, but we don't. All right. How does the pediatric airway anatomy differ from the adult anatomy? Oh, yes, I can. Is that good? Okay. The head is definitely proportionally larger. When a small child falls from a significant height, the blank most often strikes the head first. I mean, the head is the ground, and that's first. I gave it away. A. When assessing a conscious and alert 9-year-old, you should do what of these options? If the child can answer, let them answer. It's their life. The purpose of a shunt. I didn't really touch on this, but you've seen it before. We're talking about AV shunts. Shunts that carry fluid and air that are supposed to be equalized by a patient's ears and nose and mouth. But sometimes we have trouble doing that, so we'll put in a shunt. And that brings the air and fluid to the peritoneal space. What is the purpose of that? Not draining fluid from the peritoneum, no. It minimizes pressure in the skull. That is correct. Now remember, these go in the head. They're called, what do laymen call shunts? I forgot. Like what do parents call shunts? I don't even remember the slang. Yeah, maybe they just call them. Oh, they call them ear tubes. They call them ear tubes. So, like, you'll hear a parent say, "Yeah, my child had to have tubes," which is so weird to us. They're actually called atrioventricular peritoneal shunts, AVP shunts, and their job is to equalize pressure in the skull because this person has trouble draining. This person has trouble relieving air and fluid that's in excess in their head. So it'll cause chronic ear infections, for example. Those people get AVPs. And there you go. A ventriculoperitoneal shunt is draining the air and fluid away from the head. Which one? So, normally I aggressively go against your two good answers, but yes, you're right. A is not a bad answer. However, it listed something specific, and I don't like that. Febrile seizures are not commonly indicative of meningitis. If it had just said febrile seizures can indicate an underlying serious condition, I would have been on that all day long. But it suggested meningitis, and that's just not true. So I have to do away with A. Most febrile seizures occur between 2 months and 2 years. That's false. They occur between 6 months and 6 years. So B's out. C, febrile seizures are rarely associated with tonic-clonic activity, but last more than 15. They do not last more than 15 minutes, and they can be tonic-clonic, but that is not common. So C is out because they normally last less than 15 minutes, and they often do not have a postictal phase. So D is correct. I've already gotten on my soapbox about that, so I'll leave it alone. But they are normally short, brief, below the age of 6, and they don't result in significant confusion. Easy peasy, which one is it? Epiglottitis, because I saw drooling. Trigger word. Probably. We would never do A because of Y. A is completely wrong because of Y. Airway, airway, airway. We don't give stuff by mouth to people whose consciousness is declined. Monitor the child for vomiting, administer oxygen, transport. That's going to be a hard answer to beat, right? That's going to be a tough answer to beat. If you can't disprove it, that's a tough answer to beat. When using the child abuse mnemonic, what does the D stand for? Very good. Delay in seeking care. I like that they gave B, even though it's kind of funny, and you might be like, why would they suggest that? A lot of people believe that children are harmed on a large scale by divorced parents. And the data would suggest that children are harmed by parents who should have divorced. Y'all are really making this difficult. If you're wondering what's happening, all of this noise has been Scott each time. The 9-year-old and the 11-year-old, they're sitting quietly over there on the phone, not messing with anything. That's all Scott and this one cat, if you're wondering. So thank him when you see him for his distraction techniques. But a lot of people think divorce parents equals bad things for children. That isn't backed by data. Does it have some impact? It does. But you're going to see that in a couple of questions. Suicide also gets talked about in the world of divorced parents, leads to suicide, not backed by the data. So I don't like stupid stuff like that. People don't get to opine. Things are true or they're not. Especially when it's religious people opining. I get real upset. Fell from a second-story balcony, landed on the head. Unresponsive, slow breathing. My. Bleeding from the nose. Oh, Thais. 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 You're killing me, Boo Bear. You're killing me. We don't put MPAs in people who smack their head after falling from a high place. C goes in a organized fashion. It starts at the top of the sheet and it works its way down through the primary and follows the chronological order in every manner. That's why it's right. Manually stabilize the head. That occurs in Snackum. Open the airway with a jaw thrust. That's correct to do and occurs in A. Insert an adjunct, an airway adjunct. It doesn't even give which one. That's probably better than the specific. And then begin assisting ventilations for that slow breathing. C is organized and it follows the chronological order of the sheet. AVPU stands for what with the P? This is such a stupid question. Pain. Maybe it wasn't stupid in the beginning of the class, but it's stupid now. All right, kids. Go to lunch. Come back at 1:30. 1:30.
You are now muted. You are now unmuted.
I think I have selected all the buttons to push, which is annoying because there's 700,000 of them. If you're back with me, raise your hand. What a delight to be with you people. But there's only 14, 17. Okay, here we go. Now we're getting somewhere. Jacob Wynn, are you with me? Lauren Anthony, are you with me? Patty Mae Melting Sun Olick, are you with me? Oh, who's we, Jonathan? Jacob Wynn is on his phone, so I won't kick him out. Patty Mae, where is your Patty Mae? Oh, yes, Jonathan, you are my absolute favorite. I just adore you. I don't know how I'll move on once you have graduated. Megan Jones probably has Patty with her, so she's going to tell me that. And I think they're on a call. Oh, they're on a call, huh? Okay. Never mind. Okay. There you go. That's better, Patty McPherson. Who am I missing? I see. Okay, that's everybody. Good. Lower your hands, which means, Patty, don't randomly add yours to it. And that was 35. Let's pull 36 and 30.
You are now muted.
Okay. Sorry. Scotty was.
You are now unmuted.
All right. Let us go to chapter 36. The geriatric patients. We're not going to be in here much longer today, so that's good. You'll have more time to study, take adaptive tests. I'll have more time to research your adaptive tests and make sure you're good to go. Please don't forget to study the level 4 reviews because they tell you the answer. And if you memorize that, you'd probably do really well on the exam because it's the same question. They are the same questions. So don't forget to look at the level 4 review. Some of you need a good module grade, like you need a touch from the hem of his garment. So I would look at the level 4 reviews and I would do as many adaptive testing as I can. So I decided to download the EMT Pocket Prep app myself and pay for it because it offers a lot more than just EMT. It also does FPC review, it does paramedic review, and I've really enjoyed it. So if you haven't done it, first of all, there is a free version. The free versions you limits you like per day. I haven't found yet the limit to the free version because I haven't hit that limit, but I'm sure some of you probably have. So if you know what that limit is, you can speak up. But I've done like 4 or 5 quick 10s and it hasn't kicked me out yet per day. I've really enjoyed it. So if you haven't downloaded the app, if you haven't done it yet, I recommend it. And I plan on doing 1 or 2 of those quick 10s in class together because I think they're pretty helpful. So there's that. Let's get into geriatrics. When we look at geriatrics from the GEMS diamond. So go ahead and commit that to memory. GEMS diamond means geriatric environmental, medical, and social considerations. Geriatric patients, in a lot of ways, will be looked at from our eyes like the pediatric population. They're susceptible to very similar things. The additives for geriatric are the chronic illnesses. They have ongoing illnesses that have probably been managed for quite some time. And the older they get, the better we are at modern medicine. People are living longer. And if they're living longer, it means that they're also having to treat and manage these chronic illnesses for longer periods of time. We're now more able to save people who have heart attacks. We're now more able to save people who experience strokes and liver failure and renal failure and debilitating communicable diseases like tuberculosis, HIV, hepatitis C. Because we're getting good at medicine as time goes on, then people have to be managed for a longer period of time. And what we've come to know is that what has been wrong with the person before is likely what's wrong with them today. So a good sample is really important for geriatric populations. Anyone over the age of 55 is where we should start really thinking everyone needs a 12 lead, everyone needs a full workup from head to toe. We should look at everything because the organs work together and they get upset together and they chronically get ill together. So think of it from that perspective. Environmentally, you're asking yourself, is this place safe? Wherever they are. Is it too hot? Is it too cold? Are there groceries? Do they have a way to eat? Do they have a way to call for help? Do they have someone watching over their medications? You're going to find out in this chapter that geriatric patients are very exposed to polypharmacy. So polypharmacy is simply the taking of lots of medications together. And they normally need help with that. Now, the chapter is going to be very clear. I'm summarizing generalities. The chapter is going to be clear that we shouldn't assume anything. This, for all we know, this person who's 96 might be better off than you. So we can't assume that they're deaf We can't assume that they're blind. We can't assume that they take 50 medications because most old people do. We can't assume that they will fall and break a hip any minute. You can't make assumptions like that. You've got to respect the fact that they've been through life way longer than you. They're owed your attention and your time and your patience. So yes, all that's true. But there is commonality to the fact that most of them have chronic illnesses that kind of intertwine or run together. And so then they take medications that don't like each other. One pill that they really need for one condition goes against another pill that they really need for another condition. That's called polypharmacy, and it can land them in the emergency room. One example of that is that chronic pain medications result in constipation, and then they go on medications for constipation. Well, elderly people do not tolerate diarrhea and vomiting very well. They'll run out of volume very quickly. So you got to be careful. Which one's worse, the pain or the constipation? Are we over treating the constipation and now we have diarrhea? So it's a constant back and forth with the geriatric population. I'll also remind you to think of stable. Stable worked for the peds population. It's going to work for the geriatric population. Sugar's a problem for them. Temperature is a big problem for them. They get colder faster. They don't maintain their body heat very well. Their skin is very thin, so you've got to make sure we don't knock their elbows on the side of the wall when we're coming through their house with a stretcher. That happens all the time, and it results in skin tears. Those skin tears are not only bad for the patient, they're bad for you. Skin breakdown is a very litigated event in court. In fact, it's so often litigated against hospitals that almost every hospital I go into now has a chart on the wall that requires 2 nursing staff members to admit patients, and the reason is they've got to look the patient over head to toe and prove that they came into the hospital with the bed sore, that they did not get the bed sore from the hospital. So skin breakdown and skin integrity is a big deal for the geriatric population. So make sure we're not skin tearing this population. It's not free. It's not a whoopsie. Here's a band-aid. It actually can land you in court. So be careful with the skin of your geriatric population. Remember that they take blood thinners. A lot of them take blood thinners. The most common reason to take blood thinners is for heart arrhythmias and for previous histories of blood clots like strokes, heart attacks, deep vein thromboses. Those are the reasons people take blood thinners. And those blood thinners obviously put them at much higher risk of stroke, much higher risk of bleeding, especially into the brain. So if a person older than 55 on blood thinners has had a standing height fall, that might not get your attention if it was a 30-year-old, but if it's a 55-year-old who takes multiple blood thinners, I would really want that person to be checked out. Because as we've learned, the illnesses that come with falling for elderly people include subdural hematomas. And subdural hematomas initially don't have much symptoms. As the hematoma goes on, hours down the road here, we've gotten a refusal from this fall and the patient is staying at home. They get sleepier and sleepier and sleepier, and then they're unconscious, and no one knows they've got this bleeding on their brain because we did a refusal on a fall. Now, does that always mean we can keep them from refusing? No, they still have their rights if they're alert and oriented to person, place, time, and event. If nobody has power of attorney over them, if they are of their own reconnaissance, then we have to respect that. But we should inform the patient that they are at higher risk of these particular illnesses and injuries. Okay? You are going to see some test questions that talk about the aging of our neuro, cardiovascular, respiratory, renal, hepatic systems. On a general understanding, as we age, these systems slow down. They become less efficient. They require more work to do the same job, if not more work to do even less of the job that they were doing 10 years, 20 years ago for this patient. The brain itself actually gets smaller in the headspace. That's organic atrophy. The brain actually gets smaller. Now, that depends grossly across the populations of people. There are people who experience little to none, and then there are people who see a measurable amount of brain atrophy as they age. Of course, that comes with some changes in mentality. It comes with changes in cognition. So, as we age, we potentially run into the neurological problems of Alzheimer's disease, where there's a memory issue. You need to revert back to your understanding of dementia versus delirium. We remember that dementia is the ongoing progressive memory loss of our patients. So, this is a chronic thing. And then dementia is compared to, but different from, delirium in the fact that delirium is acute. It is a acute onset. It is a change. It is a person who was at their baseline before and is now not. Can a person with dementia, an elderly person with dementia who also maybe has Alzheimer's, by the way, they don't go together. You can have one without the other. Does a person who has dementia also have a risk for delirium? Yes. A person who also has dementia can have delirium. So don't get complacent. Don't think that because a person has dementia, their current inability to name themselves or say where they are or tell you what event led to EMS being called, you can't assume that that's related to their dementia. You have to assess the patient, and in the absence of other findings, we might err on that behalf. But if a family wants a dementia patient transported because they're getting worse, that's important. It may be related to their chronic illnesses, but it may not be related to their chronic illnesses. What if it's a brain bleed? What if it's a stroke? What if it's sepsis? One of the most common presentations for sepsis infection in the elderly is altered mental status. So basically, with the elderly population, the rules don't really apply. What you could have used as a guidance for a 30-year-old and a 40-year-old is not going to be as reliable in a 60, 70, 80-year-old. You got to have a high index of suspicion. So pay attention to those neurological, cardiovascular, respiratory changes. The lungs don't hold as much air. They don't exchange oxygen as efficiently. So they end up taking these shorter breaths, these low volume breaths that don't exchange as much air. So you got to think about stuff like that. We talked about Alzheimer's disease, which is a progressive organic change in the actual brain. It's a physical change in the brain where the patient will eventually, for a lack of an easier way to describe, eventually this patient will not know who they are. They won't know their family. They won't know their location. They won't know their history. It starts with amounts of loss, and it ends with a significant loss in the person to the extent that they have no memory of self or others. So that's hard to watch. It's a very debilitating disease, and it does result in death. Alzheimer's disease is fatal. We have some treatments out there. We're better today than we've ever been for Alzheimer's disease. Dementia is a symptom of Alzheimer's disease. Dementia is a symptom of Alzheimer's disease. You need to know that. Okay? Abuse and neglect is still a big deal for them. We've talked about that a lot. We talked about the Jim's Diamond. Avoid ageism. Assume nothing. Assume nothing. Not all old people fall in the same categories. Sedentary means kind of stays at home, stays in a recliner, doesn't move a lot. That can make them susceptible to blood clots. That is common for elderly people, but it is not true of all of them. There are elderly people who can take care of themselves and do not need a lot of assistance. These are the common illnesses that you will see in your sample OB/QRST for the things these people are treated for and taken care of for daily. Again, they're taking a lot of medications. That polypharmacy becomes a big deal there. Pneumonia is very common for them. So when you're not taking big breaths, you're not clearing out those bad bacteria, and that can accumulate and cause lobular pneumonia, where the pneumonia kind of sits in a little pocket and is allowed to develop. So if a patient is elderly and presents with altered mental status, you got to think whether this is pneumonia or a UTI. Those are the super common infectious risks for the elderly population, especially if they're in a living facility like a nursing home, assisted living, a retirement community. They're around a lot of people exchanging bacteria, and if they're not taking these big deep breaths, or if they're, more sedentary in nature, they might be accumulating this pneumonia. So altered mental status should make you think in the elderly population, is this a big infection? UTI and pneumonia being the top two offenders there, in my opinion, especially in women. Okay, especially in women. Remember that the elderly population doesn't produce a fever very well. You lose that mechanism as you go on in life. You don't necessarily spike a fever. Will they get a little bit? Yeah, but they're not reliable in that regard. If a pediatric population runs into a septic event, you're going to see fever. The hypothalamus is going to do its job, and it's going to do it really well, and you're going to see fever. You don't really have a lot of that in the elderly population. So you can't be looking for fever as your best compass with infection. Should we check it? Of course we should check it. Is it still reliable if you find it? Yes, if you found a fever, it is still very reliable. But the absence of a fever shouldn't make you feel safe. The absence of a fever shouldn't make you think, okay, well, then this is not pneumonia, this is not UTI. Because in that population, that wouldn't be true. And that's kind of true for all things in medicine, guys. I say that a lot, that the exclusion of something as a finding is never as helpful as having found it. The fact that someone doesn't have a symptom will never help you as much as finding it in someone. So you got to think about that. Don't get complacent. Don't ever think that because a patient doesn't present with something that it must not be blank. Not all patients follow the rules. So you can't really use the exemption of a finding as to be helpful in the amount that finding it would have been. So keep that in mind. They do tend to have pacemakers, which you already know. This is going to tell you about atherosclerosis. Atherosclerosis is the hardening and plaque buildup on our arteries as we age. The food and diet that we have is what causes that. Even some medications and our exercise regime might even partake of making or not having a buildup of that plaque. We do say that they tend to have silent heart attacks, as you're seeing on the slide here, and especially in women, because they don't feel as much. If that person is a female and they have diabetes, you know that their nerve endings aren't talking as well as yours and mine. So the absence of chest pain in an elderly person who looks sick to you shouldn't make you discount the possibility of a STEMI. In fact, we keep that rule that anyone over the age of 55, especially the female population, especially the diabetic population, we get a 12 lead on every one of those people, even if they don't complain of chest pain. The reasoning being that you can't discount it in the absence of that complaint. Remember that something is way more helpful if you find it than it would ever be useful for you in excluding a field impression in the absence of it. Heart failure is a big deal for them, so swelling in their feet and ankles and legs and knees is a big deal for them. Give me 2 seconds to check something. I think the dog just threw up. Be right back.
You are now muted. You are now unmuted.
Thank you. Sorry about that. We're safe. Didn't happen. Thank God. Whoa. Sorry about that. Sorry about that. I got kicked off. Y'all still with me? Put your hands up. Okay, great. Thank you. Okay, great. Thanks. All right, the dog did not throw up, so got lucky. Sorry about that. So let me make sure I am recording. It is recording. Mic is on. This is recording. Mic is on. Everyone's happy. Okay, carry on. I did not let the dog in us. I promise. It did not miss us. All right. Noting the swelling in the feet. If they were complaining of breathing trouble also, I'd be looking for that JVD. I'd be looking for rails in the lung sounds. I'd be looking for a low SpO2 that doesn't respond well to oxygen. If that's the case, I've got to suspect that their heart failure has now become left heart failure, and left heart failure backs up into the lungs. As you can see here, right heart failure backs up into the periphery. We've discussed that before, that the fluid backup is going to occur from wherever the side of the heart is receiving that blood. So if the right side of the heart backs up, it would back up into the periphery because the right side of the heart is receiving its blood from the periphery. The left side of the heart receives its blood from the lungs. So then that's why if the left heart fails, then it backs fluid up into the lungs. So you got to know that. You're going to see that on test questions. It can also cause ascites. And so ascites is a buildup of fluid in the abdomen. And you'll actually see these patients come in with literally what looks like quadruplets in their belly. And this man has a belly that's so tight, if you press on it, it feels like a rock. We sometimes have to drain that fluid because it has backed up so much. This can happen if the heart fails. Okay, obviously if you get ascites, it will actually mess with your breathing because that fluid will push on the diaphragm and you won't be able to draw a good breath. So the patient might complain of trouble breathing. So heart failure is really important. Pay attention to that. Heart failure comes with a complaint of paroxysmal nocturnal dyspnea. And that's the stuff I've been telling you about when people say, I can't sleep lying flat. I've been putting more and more pillows underneath me, and eventually that wasn't enough, so I had to just relocate to the recliner. And if I'm sitting straight up, I can sleep, but if I try to lie down at all, any amount, then I can't sleep because I can't breathe. That's called paroxysmal nocturnal dyspnea, and I've got to really worry if that's because of fluid. You guys know about stroke, and of course this population is pretty susceptible to stroke. It does talk a good bit about pain receptors in the elderly population. Their pain receptors decline in function. So it takes them a longer time to receive the message that, ouch, that hurts. So the example the book gives is that an elderly person might have their hand on a hot surface for a longer period of time and sustain a larger amount of burn, a more deep burn, a deeper burn than you and I, because our brain would have said, get off of that faster than their brain did. So there's an example of that particular change in the neurons and how they respond to the brain. I already covered all of that. A triple A, you need to make sure you remember that that's abdominal aortic aneurysm. And the common symptom complaint there is chest pain or abdominal pain that radiates into the shoulder blades or radiates into the back, and it feels sharp and burning and stabbing. That would be a super concern if you were hearing those types of complaints from someone who had a really high blood pressure. I'd be really thinking about abdominal aortic aneurysm. We talked about HHNK or HHNS as this one's going to refer to it, but basically that's just another way of becoming acidotic and high sugars, hyperglycemia. We already discussed that in the endocrine chapter. Remember to emergently transport those patients. There's not a ton that you can do. Of course, they are more susceptible to toxicology because their bodies don't metabolize as well as you and I. So when they take a dose of medication, that medication stays in their system much longer than your medication would. So they're normally on reduced dosages, or they're normally on a less frequent timing for each dose than you or I, because their hepatic clearance and their renal clearance is delayed. Where yours and mine are maybe more efficient, we're clearing out that medication faster, so then we require bigger doses, we require more frequent dosing. They are the opposite of that. We already talked about the Jim's Diamond. The social assessment is really important. Who comes and checks on you? Who lives with you? Who comes and makes sure your medications are okay? Who makes sure you're getting food? Do you talk to your children? Do you have friends? Do you have family members that you interact with? Do you go to the Senior Citizen Center? And that's your social aspect. There's a lot of senior citizen centers in bigger cities and counties, and the whole point of those centers, they typically will have a small gym and they'll have an activities director where literally the aging population can go for coffee and television shows and interact with other people their age and just kind of be out of the house. And there's medical staff there that can help if needed. It is based on your level of dependence. So some people that go there receive a high level of services because they need a lot of interaction and care. And then some people go there and work out in the gym and they need almost no assistance or care. Dorchester County has a very large senior citizens center where there's a gym and activity center and there's meals prepared for them. So they have a cafeteria, and it's kind of just a means for them to check the social box, as we all need. All of us need that box. And so as we get older, our ability to make that, to check that box is a little different, based on each developmental stage of our life. I already covered all of that. Osteoporosis, as you know probably already, is the breakdown of bone. Basically, as we age, we don't have the amount of bone density that we had before. So breaking bones becomes much higher of a concern for us. A fall that you would think a 30-year-old never breaking something from could easily result in a broken bone in an elderly patient. In fact, one of the most memorable things I have seen from Scott's patients is that he had a patient who broke their femur walking because of bone density. So osteoporosis is the breakdown of our bone density, and it's from many different things, and medications, simply aging. There's a point in which we age enough to cause osteoporosis. Vitamin D deficiencies, calcium deficiencies, even severe diseases can cause osteoporosis. There was a pretty heavy understanding that diflucan or antifungals could cause bone density eroding. A lot of elderly patients have that. You got to be much more suspicious of them having broken something with less mechanism of trauma. We already talked about all of that. Do make sure you're padding the voids, because as they age, the spine is not as flexible. So make sure you're patting the voids. It also talks about something really important here. Elderly patients are pretty susceptible to something called poikilothermia. Poikilothermia is when your body as a whole or individual parts of your body assume the temperature of the ambient around them. So if you put an elderly person on a cold surface, it's likely that they will radiate their heat into that surface. The surface will conduct that person's heat and they will lose it. They will lose that body heat. So put blankets between them and the board. Put blankets between them and the stretcher. That's a very common thing for us to do, and it's a very good thing for us to do so that they retain more of their own body heat. Remember that they're not very good at their own temperature management. MRSA, we've talked about before. This is a bacterial infection that became because we overprescribed antibiotics. And so MRSA in this case is methicillin resistant, a family member of the penicillin regime. And this particular bacteria is intentfully resistant to it, and it makes it very difficult to treat it. So you have MRSA around you already, but your body is strong enough to fight it. As we age and our body is not as immune efficient, then we do become more susceptible to these nasty bugs that were created by the healthcare environment, and they may get MRSA, especially diabetic patients they don't have as good of blood flow as you and I. So the bacteria is allowed to accumulate at a higher rate because they're not able to get their white blood cells to, say, they scratch their toe on a piece of furniture in the house. That could become an MRSA event for them because they're not perfusing that site very well, and therefore they're not fighting that bacteria very well. You can get MRSA onto you, so you just got to be washing your hands, and typically, even if you did get MRSA on you, your body would deal with it, and you would not get an infection. But good, clean hand washing and, being aware of your PPE is going to prevent that from happening. I've been doing this a long time, and knock on wood, I haven't caught MRSA. Not to say that it won't happen to me ever, but I haven't, and so that's because I try my literal best to wash my hands after every single patient contact. And I make a big deal about the stretcher and the equipment and wiping all that back down, and you need to do that as well. We should be very concerned about this second line right here. Many infections in hospitals are caused by bacteria that are resistant to vancomycin. Vancomycin is one of the strongest and the go-to drugs, intravenous antibiotics that we use. If you are resistant to this antibiotic, you are susceptible to sepsis because this is one of our go-to attacks on sepsis. And so if this doesn't work, we've got to pull out the big guns, and that comes with complications. It comes with a big deal. So the point being, it's important for us to try to not let people catch infections that they caught from the healthcare environment. Clean your hands, clean your stretcher, clean your stethoscope, clean your cardiac monitor. Make sure that the next elderly patient in the back of your ambulance isn't going to get an infection, not because they were exposed to somebody, not because they were in town and someone's coughing and sneezing on everything, not because they went to the senior citizen, but because they called for help. That's not something I think we should be swallowing very well. We shouldn't be running around giving people infections. I talked about C. diff before, Clostridium difficile, and Clostridium difficile is basically the raging diarrhea bacteria. Your body has C. diff in it, in your gut. You have C. diff. It is kept from causing a problem by the good bacteria in your gut. But if you get put on a medication that kills your good bacteria, or if you aren't clean enough and you're catching C. diff from other patients, you're going to be sorry. It is very hefty, and you're going to be on an antibiotic for some time to try to clear it up. Alcohol sanitizer does not kill C. diff. If you aren't washing your hands, it is a matter of time before someone will give you raging diarrhea. And when I say raging, I mean you're at the red light, you hit the brakes, and that was enough to flow. And that's pretty embarrassing and very miserable. You don't want that to happen to you, so wash your hands. Obviously, elderly people do tend to have DNRs if they have a non-treatable terminal illness in this state. So that's always a good question to be asking. I'll let you read the other ones because they don't apply to our state, but they do apply to the National Registry, so you could still read them. You should still read them. I already talked about all that. All right, let's answer some questiontos. Definitely D. Stroke, diabetes, and heart attack are chronic illnesses. That's what's going to kill them. Do elderly patients overdose? Yes. Is it common? No, it's not common. If they do overdose, it's typically by accident. Yes, Clayton? Are you just hitting buttons randomly? Activities of daily living are brushing your teeth, cooking your food, changing your clothes, going to the bathroom by yourself. Activities of daily living is social, people. Social. Eating, brushing your teeth, going to the bathroom, getting dressed. All those things are social components. Environment would be temperature. Environment would be shelter. Environment would be if you're exposed to risk levels like, exposed wiring in the wall. That would be an environmental concern. Activities of daily living is a social concern. I don't know who's going with glaucoma, but I don't think you read that one very well. It's a cataract. A. Very good, Mila. It is D. C is not correct. Just because they've experienced an emergency doesn't mean we can throw them away. So, Kate, we're not going to allow Kate to manage our grandmothers. although, although Kate, I probably would do the same. But it's D. We talked about the fact that slowing reflexes in elderly patients cause more illness, more injury. So they would experience a deeper injury than you and I because they don't remember to pull back. Their brain doesn't tell them to pull back as fast as you and I. Yeah, this is dementia. They could have made this a little more difficult on you by putting the word Alzheimer's in here. And it wouldn't have been a very fair question, but remember that delirium, no, not delirium, dementia is a symptom of Alzheimer's. They're not the same. In this particular case, it's a slow onset, so that makes it dementia. If it had said acute onset, then that would be delirium. Some of you were a little more hesitant to answer this question, but you have a history of high blood pressure and vascular disease. So anytime I have a high blood pressure over a long period of time and vascular disease, you're going to get an aneurysm. And in this patient's case, we have a dissecting aneurysm, a patient who has low blood pressure, a very high heart rate, high breathing rate, and a rigid abdomen. This sounds like they're already bleeding into their abdomen from this aortic aneurysm. Come on now, Jonathan. They don't decrease in blood pressure, they increase in blood pressure. If we get atherosclerotic, that's going to increase blood pressure. If the tank gets less elastic, if the tank can't relax very well, if the tank is full of plaque, then we're not going to decrease in blood pressure. We said that the organs tend to decline in their capabilities, and so C would be the answer here. And the reason is because as we age, we're literally losing those cells and the organ declines in its efficiency. It's still trying to do the same job, but it isn't as efficient. It requires much more resources to accomplish even the same amount of work, but most likely it requires more resources to accomplish even less work. So as we age, the brain, the heart, the lungs, the kidneys, the liver are declining in their capabilities, as I said during the lecture. Sorry, Jonathan. I didn't mean to kick you while you were down. The answer is C. Which of the which of the following conditions makes the elderly patient prone to fractures in even a minor mechanism? Yeah, I said that one almost verbatim. So osteoporosis. Polypharmacy is obviously someone who takes a whole bunch of medications, and those medications tend to find issue with one another. Inflicted bruises are commonly found in all the following areas except I hate this question. I believe that C would be a more intelligent answer because the inner thighs are the most protected out of these options. You don't typically see people with their legs open enough for the general striking of a patient to result in bruising in that area. It doesn't make sense to me. But their answer is D, which is odd to me. Let me tell you why it's odd to me. The forearms being bruised is a very concerning sign because we defend ourselves by putting our hands up and out towards whatever is striking us. So the fact that they think that inflicted bruises aren't commonly found on the forearms is in direct contrast to any pathology class that you would take, any investigations class that you would take. They're called defensive wounds. It is very common for people to throw their hands up to keep you from hitting them when you're trying to strike them. So I don't agree with this answer at all. I think they got this answer pretty wrong, and they should remove this stupid frickin' question from the book. But it's on here. I think you should ignore the crap out of it because whoever wrote this question is stupid, and putting it in the book was stupid. So there's my take on that. And that's why you got it wrong, because they're stupid, not because you aren't using your brain. All right, let's take a break and come back at 2:30 and we'll finish the last chapter. 2:30.
You are now muted. You are now unmuted.
Okay, welcome back, people. Let me get them hands. Come on. Let me get them hands. Put them up. Wave them in the air like you just don't care. Shut up. Australia. Sorry, children, that's the talking daughter who would talk in her sleep if her brain would let her. Let's see who's missing from the hand count. We got 18 people, 19 and 20, so we're missing one person. That's Patty, but we know Patty's here. Right, Patty? You're here? You're on listen mode only, but it should let you text. Patty? Don't make me throw you out, Patty. Megan, do you have eyes on Patty? Do you know if Patty is with us? Alright, he's on listen mode only, so I'll text him because technology's not his thing. Alright, Patty is with us. Patty is with us. Moving forward. Shooby-dooby-doo, shooby-dooby-doo. This is the last chapter in the Special Populations module. And, although I would argue that it's an easy chapter, but you're going to have to look at the definitions of chronic illnesses that you may not have heard before. So I don't know if it'll be easy for you, but the general idea from this chapter is rely heavily on the people who take care of the patient every day. Those people have been trained by the doctors before this person got released to go home with these parents, caretakers, family members, spouses, children. Whoever is taking this person home from this significant diagnosis or maybe even chronic management, they get trained. So say you're going home with a feeding tube, they get trained on how to do that. Say you're going home with a home ventilator and a home trachea, a home tracheostomy. They get trained how to deal with that. So the people who take care of the special challenge patients, they are your resource. Rely heavily on them. When you read the chapter, focus on the diagnoses that you aren't familiar with. You need to memorize what muscular dystrophy is versus myasthenia gravis. Whatever the diagnosis is that it's talking about, make sure you know what those things mean. These populations are covered in the book here, not of substance, but they are covered. If a ventilator fails, go to a BVM. If a person's on hospice, call the hospice nurse. If a person has tracheostomy issues, transport them emergently because the family has probably done everything they can to manage the trach that they do every single day, and that's not working. So remember that you can ventilate a stoma using a small mask and a BVM size that is appropriate for the patient. So tracheostomies shouldn't scare us, although they can run into significant trouble. So be prepared to transport the patient emergent if you need to. Remember that you can't suction inside of a tracheostomy, but you can suction around a tracheostomy. I'm going to go on into see if any of these are important. Again, trust the people who take care of the patient every single day. These are your MR patients. Intellectual disability is a very 2022 way to say MR. We used to say clinical mental retardation, but apparently that's become a socially unacceptable terminology. So we're going to call it intellectual disability. Intellectual disabilities can be of great range. You can have people who are pretty okay on their own, and then you can have people who, even in their adult life, would need to be living with a parent. So you've got to kind of find out what is the norm for that patient. And so, again, lean on the caretakers. Autism, if you don't know, is a pretty scary disorder that leaves a person, more specifically children, typically. As we become adults, we get better at managing autism, depending. It's also a spectrum. It's also a wide range of functionality, whether this is high functioning or low functioning autism. But generally speaking, autism is a person who knows what they want. They can hear, they can talk, they can smell, but they can't get it out to you. They don't know how to articulate themselves. And that is a range. It can go all the way to nonverbal, never speaks, has never spoken, up to a person who is literally a genius. So autism is quite an array of issues. Um, they're saying here that it's an intellectual disability. I don't know that is a great way to term it, since some people on autism spectrum are the most successful people we have in our world. If you're familiar with the word Elon Musk, these people can have very high functioning lives. They can also be on the very low functioning side where they, literally are kept in a very confined area and their daily living life is very confined. So you got to, again, lean on the people who know the patient. Talk to the caregivers. What is the normal? What did you call for today? What's abnormal today? How do you want us to address this? A lot of autism patients have feeling sensory issues, so loud noises, certain sensoriums like feeling. I know a particular autism patient that likes to hold on to a plastic bag, like the one you would get from Walmart. And if this child has a plastic bag that he's rubbing in his hand, all is well. You take that plastic bag away and he might literally strangle you. So, it's a wide range. Walking on your tippy toes is a characteristic that I've seen a lot with autism. Loud noises not being something they can tolerate. You'll see children sometimes in public who have earmuffs on, like the same ones you would see on a gun range, and they're colorful and pretty and they've got all kinds of designs. That's not a mistake. That's probably an autism patient. Some of these patients even wear helmets because one of their go-to responses when they get upset is they'll bang their heads. So you got to find out what's normal for them. I have a huge spot in my heart for autism. If you have not watched the Netflix series on autism, where the psychologists and psychiatrists and the physicians that treat that go into what is happening to them, you really have missed out. Basically, they are just as smart as you are, but they can't get it out. Could you imagine being inside of yourself and unable to communicate? You know what to say, you know how you want to say it, but you can't. For whatever reason, you can't get it out. And that just kills me to think about that. So please be patient with them. Know that they can get very violent. They can fight. And when you try to get on them and hold them down, it isn't helping them very much. There's a lot of data that's pretty clear that when we have to physically restrain these types of patients, it's very traumatic for them, and it does have an impact on them long term. And I would suggest to you that if these patients endure that kind of setting multiple times throughout their life, that is probably impacting their mortality. So we should try our best to work with our mouths and the parents, the people who know this patient the best, because they're probably going to get the best resources. Now, of course, they wouldn't have called us if they didn't need our help. So we're going to be there and we're going to help them, but we need to lean on those people as to what to do. Let me see, Jonathan. I will research that for you, and I will get. I don't know the very specific name of it, but it's on Netflix. It's really good. And if you're not crying by the end of it, you call me, and I will tell you that you don't have a soul. Because it's quite amazing. It's an amazing documentary. But I'll research it. Remind me later. Super, super awesome. Down syndrome is kind of the same. You can have very high functioning Down syndrome patients. There are many actresses, actors, models that have Down syndrome. So it is also a range. Some Down syndrome patients will live with their parents forever, and some Down syndrome patients will go on to have independence and live their own lives. So, again, this does kind of have a range. I will say that airway management in Down syndrome patients tends to be difficult. They have a very large tongue and they have a very flat occiput, and that makes head tilt chin lifts, airway adjuncts, supraglottic airways, intubation. It makes it very difficult. And so just do know that, especially in the children, in the Down syndrome children, airway management is a little more difficult with them. I would probably call for ALS backup early. Not that your paramedic is going to be any better, but at least you have an additional higher level of resource there to try to manage that airway. Bag valve mask ventilation can be very difficult with a Down syndrome patient. I'll let you read through that. I'm going to let you read through that. Please don't give sign language your best go. I hate this part of the book. It's disrespectful at a minimum, and it's unintelligent at a maximum. If you aren't trained in it, leave it alone. There are resources available to you wherever you go to work to deal with a patient who is ASL. If you need those resources, then get a hold of dispatch and get the resource. Typically, a family member can help. If that's not available, then you got to do your best. And the last time I checked, people that have hearing problems can still read and write. I don't know why people feel the urge to give sign language their best go in lieu of just writing it down. Go back and forth with a dry erase board, or give your phone to the person and let them type back to you if you trust them to do so and not run off with your phone. So think of other ways to deal with that rather than Googling sign language on the side of the road. Make sure if people have devices that help them with their daily life, like hearing devices, glasses, walking canes, bring that stuff. Don't leave that stuff at home. The patient will eventually need to be returning home, and they're going to need those things. Cerebral palsy. There are some celebrities out there with CP. And CP kids are also a little bit variant, but it is a pretty debilitating disease that does follow a person most of their life. There are still some high functioning CPers out there. There is a particular TikTok star, for example. I'm not on TikTok, so I only know this because of the medical research world. But there is a TikTok star who actually has done quite well in his brand and in becoming famous. And he's out there living a great life, and he's got CP. So it depends on the patient. Are they in a wheelchair? Are they able to walk? Do they use canes, or can they walk on their own? I know a particular CPer in one of my friend's family life, and she is ambulatory without assistance. Now, it took some time, and it took a lot of therapy, and it took leg braces, but this person's now going into their teenage years, and they're able to walk unassisted. So it varies. We believe that CP is typically caused by anoxia in the birthing process or during utero. So if a child struggles to get out of the birthing canal, that's where we think CP can really become an outcome of that. So in utero, oxygen deprivation like trauma or bleeding, and then in the birthing process, getting caught in the canal, basically getting stuck in the canal. Spina bifida, pretty debilitating. They don't live very long, typically speaking. There are some surgical interventions available, but these patients do not live very long typically. If they do live long, they tend to have a lot of chronic management. Do read this chapter. Tracheostomies, a little more information on that I feel like you should have gotten from the beginning. You do need to know the dope, mnemonic, for any tube, not just a tracheostomy. If we run into any trouble with an established airway, including your supraglottic airway, when we go to troubleshoot what that trouble might be, we use dope. Is it displaced? Look at my entitle. Listen to lung sounds. Do I have gastric sounds? Am I getting chest rise? Obstruction. Is there now blood or mucus or nastiness in the tube that's not letting it give air and exhale air? Pneumothorax. Anytime we're ventilating someone artificially, we could cause a pneumothorax. So we had good lung sounds before, but now we don't have lung sounds on the left side, and there's an acute change in blood pressure. All of this is acute. That's probably a pneumothorax. So we got to be careful with that. Get a paramedic for that. They need to decompress the chest. And then what if the equipment fails? You guys have already seen that your supraglottics in the classroom, they've been used so many times that that little valve can fail on them, and they can leak the air. And if the air doesn't work in it, if the balloon doesn't inflate properly, then the entire device will fail. So that's dope. You need to know dope. We use it for intubation, tracheostomies. We use it for supraglottics. If a mechanical ventilator fails, you should bag the patient with your own BPM, preferably on a PEEP valve set at 5 or less. You don't want to just be ventilating people on a straight BVM. You want to use a PEEP valve. I'll let you read that. Central catheters like this, people are out there with them. My friend Megan won't mind me telling you that you already probably know she has a PICC line. So hers is in her arm, which is a peripherally inserted central catheter. And then this one is a central catheter, which is underneath the clavicles. Either way, these lines are for a general purpose that's normally temporary and they get taken out later. Say you have a long-term medication that you have to infuse, or say your dialysis shunt failed and you needed an emergent method to use dialysis, then you could have a central catheter for that. You want to make sure these are dry and intact as far as the dressing is concerned. You want to make sure that it's not bleeding at the site. And you want to make sure that all the things we do in our environment doesn't pull or yank the line out, especially the seat belts on our stretchers. Make sure that you're not getting these lines caught in the restraining devices that we use in our general duties. A paramedic can access these lines, so that makes our job easy. But you cannot, of course, because it's intravenous or it's central circulation, depending on the line. So if you need ALS backup, this is a gastric tube. This is how some people get food. For many, 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 many reasons. These can be temporary and come out later, and now the person doesn't have it and they go on about their business. Or it can last a long time for a person who can't eat food by mouth. We should not try to put them back. They tend to come out. Don't try to put them back. This is the ventriculoperitoneal shunts that we talked about earlier, the APVs, or AVPs, depending who you're talking to. We already talked about what they do. They basically maintain a balance of air and fluid in the head by releasing air and fluid into the peritoneal space. So drain it from the head and put it into the chest and abdomen where there's a lot more room. If they become blocked, they typically produce severe headache, altered mental status, and vomiting. Those are heavy signs that the shunt is clogged or occluded would be a more medical term. If they get a severe headache, if they start screaming and crying and they're projectile vomiting, they get a fever, or they will start becoming super lethargic, even unconscious on you, because they're not able to equal out that pressure. They're getting an increase in their ICP, intracranial pressure. I will say this about colostomy bags. There's a lot of stigma that comes with a colostomy bag. There are a lot of young people out there for one reason or another who have a colostomy, even sometimes short term. Protect these people. Be careful. This goes on the belly, right? Lower abdomen. And it's literally like an adhesive bag to the belly. Your seatbelt can unadhere it to the belly. And that makes for a very embarrassing and nasty spill. So be careful with these people and protect their privacy and protect their modesty. Some people have these little covers, basically. They're cute designs. You know, children who have colostomies will have colostomy bag covers that are really pretty and cute. And if they want those things, make sure we bring those things. That brings comfort to people, and I think we should give a damn. I really do. And so if they need that, if they want that, if they have those things, make sure we're addressing those social components. I think they're important, and certainly these patients think they're important. Don't let your seatbelt catch a colostomy bag and yank it off. You need to know that these colostomy bags have an adhesive ring that's supposed to last for more than a few days. It may even last that person a week, and they only have so many, and they're very expensive. So prematurely unadhering that colostomy is not as simple as it might seem. You might have put that patient in a predicament where they don't have another one. All right. What you got? Autism is a social, I don't even want to call it a debilitation because some of these people are incredible. They're not debilitated. They're amazing, and we just don't understand them. It is a social thing. Autism is, and that's the answer to the question. They can't get out what's inside of them. And I sometimes think that's because we're not smart enough. The people who don't have autism are not smart enough to understand them. And that's got to be incredibly frustrating. Oh. Negative. Down syndrome is not a social interaction issue at all. It is actually a chromosomal disorder. It is strictly isolated to genetics. Whether you do or don't have Down syndrome is based on your chromosomes. So that's why it can't be A. Yes, it is a trisomy 21 disorder. So that's why it cannot be A. Now, do they have social components? Of course they do. But if you've been around Down syndrome for even 5 minutes, you know that most Down syndrome folks are well behaved. They're very intellectual, even sometimes more cultural and diverse. I just love them. I just freaking love them. And they may need a lot of care, and there are a ton of Down syndrome people who need very little care. So it just depends. Known risk factors for Down syndrome include what? We know the most common one. I'm going to see if Zach gets this right. Oh, Zach said A. Sorry, Zach. Increased maternal age and chromosomal history is our Down syndrome increased chance. So it's definitely C there. The other ones, I would argue that there's some confounding data, but the book is going to regard C as being the direct answer to that question. Which of the following may be difficult to perform on a Down patient syndrome kid? Down syndrome patient kid. Anything to do with airway is going to be difficult. It's going to make it a little more challenging. So I'm going to go with D. Hydrocephalus is basically water on the brain. And yes, spina bifida patients also have hydrocephalus. And they do require AV shunts. Because 1C is not enough, Jonathan. What does dope mnemonic help you recognize? Mm-hmm. A all day, baby. What device is placed in the stomach to feed people? We don't call it a G-tube for nothing. Gastrostomy tube. We don't call it a G-tube for nothing. Now, there are other names for these, and they're based on where we accessed the GI tract, depending on their condition, why they got it, blah, blah, blah. But we do typically refer to most of these as G-tubes, gastric tubes, or gastrostomy tubes. Vagal nerve stimulators. If you know the anatomy and physiology chapter, then you don't even need to know specifics about this. And there's an answer that has multiple answers, so that's almost always correct. And it is true. Vagal nerve stimulators are an alternative to medications. That's true. And they attempt to keep seizures from occurring. They can be used as a primary line or as a response to a patient who isn't doing well with medication therapies. I've said it over and over and over. You got to interact with the people who know this patient the most.
Here's your reminder. Get off phones. Time for chores.
Thanks, Alexa. She's going to do it again. Interact with the caregivers.
Here's your reminder. Get off phones. Time for chores.
This is a confusing question, so careful. Yeah, I'm going with C. I'm going with C. B is a version of C, but there are many versions. So B is too specific. C is more global. So that's why C is the better answer. Yeah, EMTALA is exactly what it says. It says that in the United States of America, if you present yourself to an emergency room, you must receive stabilizing treatment. Now, you don't have to receive treatment past stabilization, but whether you can pay or not, you must receive stabilizing treatment. That's also true for the delivery of a baby, which scares the crap out of emergency room physicians. But EMTALA also covers active labor. If a person is in active labor and they present themselves for help, they have to be helped. You can't not help them. So that's pretty funny because emergency room doctors are super scared of obstetrics and neonatal care. And who wouldn't be? It's a specialty, so I get it. All right, kids, that concludes the lectures for Special Populations Moduli. It's been a hoot of a time. A hoot of a time. We are so close to the end of this class. I hope you're feeling it. The schedule for ride-alongs was updated again today by Charleston County. So why don't we go take a look-see? Let's see who has ride-alongs now that didn't have ride-alongs before. If you weren't scheduling yourself for Charleston County, then you don't have Charleston County ride-alongs, and this doesn't really apply to you. If you haven't finished all your stuff, I'm starting to laugh at you because you're not going to finish this class. And there's nothing I can do to make you do it. So that is that. All right. Yeah, that's good. So now everyone, Clayton, I got to schedule you. Daniel Moore, we got to schedule you. Jacob Wynn has not done his stuff. Megan Jones, I think you know what I need from you. Thomas Catlett has not done his stuff. So everyone else has been scheduled. Kendall Bloss, that's on 13's side, so I got you. As long as your stuff is turned in, and you'll be all right. If it's not turned in, you won't be. So I hope you turned it in. Tiana Whitehead. I gotta see what I need from Tiana. What from Tiana? It's just not having availability yet. Oh, no availability. All right. Make sure. Yeah. Alejandra has 16. Good job, Alejandra. Make sure these are updated, or I'm going to schedule your butt again. And you're going to be so angry. And I'm going to laugh, laugh, laugh. Because if I schedule you again, you're going again. So make sure you keep the contact number current. After every night that you've gone on a ride or every end of your shift, go put that on there. Okay. I've had enough fun with you people. Bye-bye.
You are now muted.